So hello everyone, very good evening to all of you. I'm Dr. Sonali Agrawal, IFS Executive Member of MP Chapter. I welcome you all. So on this third webinar of Polar Race, this is the unique monthly webinar on imaging in gynec and infertility. So for that, I would like to thank Dr. Priya Bhave Madam and Dr. Bela Bhatt Madam for giving me this wonderful opportunity. It's my proud privilege to invite Dr. Bela Bhatt Madam she is a chairperson Foxy Imaging Science Committee. She's a lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. She's a fetal medicine consultant, Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital, Mumbai. She's FMF UK certified sonologist and the fetal abnormalities and FMF UK certified sonologist for nuchal translucency. She is a certified trainer for ultrasound in obstetric and gynecology. She's author of book that is the Vital Skills Ultrasound in Obstetric and Gynecology. She's the Joint Secretary, Association of Fellow Gynecologists, Mumbai. She's a Managing Council member, ISPAT, and life member of SMF. She has received many.
I think that's fine, Sonali. Hello. Hello.
Yes.
Yeah. So as we all know, I would like to extend a warm welcome to all the viewers, all the faculties, all the respected seniors and friends to this very, very popular series of gynae and infertility ultrasound, which is kind of devised by both the Imaging Science Committee, FOGSI, as well as IFS MP chapter. And we all know that it is because of the IFS and the Dr. Priya Bhave, Dr. Sonali Kulkarni, and myself, Dr. Bela Bhatt, who have worked hard to design this series of webinars in order to kind of spread the knowledge about the basics of ultrasound in gynec and infertility. Now, in this series, we have already learned about the basics of nomology and the basics of pelvic scan. And also we have learned about how to diagnose fibroids and adenomyosis in the last webinar. We know that this series comes every first Wednesday of the month. And today we have someone who's very, very knowledgeable and expert in the field of ultrasound in infertility. That is Dr. Karunakaran, who is from UK and at present based at Dubai, who's going to speak about one-stop fertility assessment. And following this, we have a panel on tubal assessment where we'll have again Dr. Sonal Panchal as expert and Dr. Sonali, who's going to moderate this panel with the most knowledgeable panelists. And we are also very, very fortunate today to have Dr. Suvarna Khadilkar as the chief guest and Dr. Neena Malhotra as the guest of honor for today's webinar. So I think without much ado, everybody is waiting for the academics. So Dr. Sonali, can we have I think Dr. Suvarna Khadilkar has joined, Himanshu?
Yes, ma'am.
Yeah, Dr. Suvarna is there? Yeah. So we welcome the esteemed faculties and Dr. Suvarna Khadilkar ma'am, who's the chief guest for today's webinar. Can we have the CV of Dr. Suvarna Khadilkar? Yeah. So we all know Dr. Suvarna Khadilkar very well. Madam is at present the Deputy Secretary General of FOGSI and currently the President of Mumbai OG Society. She has been the Vice President of MOGS in 21-22, Editor Emeritus General of OBGYN India, Treasurer FOGSI 18 to 21, and
Bela.
Yes. We also know ma'am as she's very sweet person, highly academic and always there to support us for all the academic activities. So welcome Dr. Suvarna Khadilkar madam, and we are here to have your blessings today. Over to you, ma'am.
Thank you so much, Bela, for inviting me here. I like that the title of your series, Polaris, and the entire contents. I was just listening to you and I went through the brochure before joining. It's really wonderful. And I think people who are interested in both infertility and ultrasound are, quite a few people who have common interest, and I'm sure they will enjoy and learn a lot from this meeting. Especially as you say, we have an international speaker who is, I think, Dr. Karuna Karan, who is going to enlighten all of us in his one-stop fertility assessment. So that is a fantastic talk. I mean, the topic also is very, very interesting. And I take a pleasure to have Neena Malhotra as my co-guest of honor. And for Dr. Jaideep Tang, Dr. Madhuri Patel, and President and Secretary General of FOXY. Also, Dr. Pankaj Talwar and Professor Shweta Gupta, who are IFS national body. I think they have been also proactive in having your webinars, and they are so widely promoted. And I'm sure each of the webinar has high scientific content, and so the attendance speaks for itself. So I wish you all the best, and I can see our all ever ready, interested in academics, Dr. Rekha Rajendra Kumar, Dr. Uma Devi. Then we have Dr. Sonal Panchal, Dr. Sonali Agarwal, who are going to conduct the panel. And we have wonderful galaxy of stars who are going to be panelists. I can see Dr. Anuradha Khar's name. She is so famous for her group. I really like the program, and I wish you all the best, Bella. Keep doing good work. Keep doing good work. Thank you so much.
Thank you so much, ma'am. Your words of encouragement mean a lot to all of us. Thank you so much for being there with us. Thank you.
Thank you, Suvarna madam.
Thank
for your
you.
So much, madam, for your blessings.
Yeah, Dr.
So,
Sonal.
yeah. So our guest of honor of today is Dr. Neena Malhotra, madam. She's MD DNB. She's a professor and head Department of OBGYN in All India Medical Institute of Medical Science, AIMS, New Delhi. She's head of WHO Collaboration Center for the Research in Human Reproduction. She's president-elect of IFS National President in 2024-26. She's Senior Vice President IFS 22-24. She's Fellow of Commonwealth Fellow, and she is ICMR International Fellowship for Fertility Preservation, France. She has received many awards like Sir Malcolm Black Fellowship, London, and she is Overseas Funds, London, and Imaging Science Award, FOXY 2006. She has received CS Dawn Award and Orion Research Award. She has research interest in endometriosis, fertility preservation, ovarian tissue cryopreservation. She has funded many projects and she has many publications in her room. I welcome you, ma'am. Please say a few words of wisdom.
Thank you so much. I think it's a pleasure and honor on a weekday like this. The energy and I think the radiance of Polaris, as the word goes, is so obvious when you see such a fantastic crowd, a galaxy of speakers, and not from just India, overseas. And it's evident, the testament of the attendance is the evidence to say that this is such a popular program. As a core member of the Indian Fertility Society, I take it a pleasure that with Dr. Bela's leadership, this partnership or synapse is doing so well. And I know the series, as is moving forward, this would also be another, feather in the cap of the Polaris. So I wish this webinar a full success, and I look forward to the deliberations, which will sure benefit all the ones who are present. Thank you so much for having me here once again.
Thank you so much, madam, for giving us valuable time and your blessings. So I would like to invite Priya Bhavi, madam, to give some insight. She is FNB Reproductive Medicine, and she's a teacher, ex-faculty, DM Reproductive Medicine, FOXY recognized trainer for the basic and advanced fertility courses. She's Cochrane reviewer and author. She is the secretary of MP chapter IFS. She's awarded with Pankaj Talwar Gold Medal at FOXY 2022. She's the Ironman triathlon also. Priya, madam, are you there?
Yeah, I'm here.
Yeah.
Thank you, Sonali, and thank you to Bela madam, because she is the entire brain behind all this. My sincere thanks to Bangalore Obstetric Gynae Society for joining us in this endeavor, and a very warm welcome to Nina madam. She is the president-elect of IFS and is also contesting for the post of chairperson Imaging Science Committee. So, ma'am, we wish you all the best, and let's get on with the proceedings.
Thank you so much, Priya madam. So now we'll move on to our first session. Everybody is waiting for our academic session. The topic is One-Stop Fertility Assessment by Dr. Karunakar sir. For that, I would like to invite our esteemed chairperson, Dr. Rekha Rajan Kumar madam. She is currently the president of Bangalore Society of Obstetric and Gynecology. She is practicing since 32 years, and she's Diploma in Human Research Development, Diploma in Health and Hospital Management, and Diploma in Hospital Administration. She's the director of Miracle IVF Hospital, and she's the chairperson, Ethic and Medical Legal Committee of KSOGA, and she's the South Zone Coordinator, FOXY, Medical Disorder in Pregnancy Committee 24-25. She is CE member, Karnataka branch of Indian Society of Assisted Reproduction. She is the chairperson, Fertility ART Committee. She is the South Zone Coordinator, founder, CE member, Karnataka branch of IFS. She is a life member of 10 prestigious societies and peer reviewer of Journal of Obstetric and Gynecology of India. She has awarded many awards and 7 facilitations, and she has 27 original articles and case reports, and she has more than 100 radio and television talks. So I welcome you, ma'am.
Yeah, thank
Next
you. Okay, fine. Yeah, sorry, please proceed.
Welcome, ma'am. So now our esteemed second chairperson is Dr. Uma Devi, and she is the Honorable Secretary of Bangalore Society of Obstetric and Gynecology. She is currently the Professor and Head OBGYN Santosh Hospital, Bangalore. She is Secretary of Bangalore Society. She is visiting Professor Ramaiah Medical College since 2012. She is external member board of studies, Ramaiah University. She's the past professor, Madras Medical College. She's DNB teacher. She is assistant and associate professor, and HOD, Ramaiah Medical College. She has received many awards. She's WHO Fellow Gynec Oncology UK, St. Bart's, London, RCOG Overseas Award. She has received the Anman Lord Chalk Award, Memorial Prize, and she's many first prize in first in DGO Madurai University. She is trained for urogynecology, ultrasonography, obstetric and gynec, Doppler, and fellowship in daycare endoscopy, fellowship in infertility, and she has many publications, national, international. She has written many chapters. She's a very good teacher. So I welcome you, madam. Thank you, Doctor, for this webinar. So I request chairperson to invite our esteemed speaker of today, Dr.
First of all, congratulations, Bela, for this Polaris series going very strong and becoming very popular. Thanks for this imparting knowledge on such a strong platform to all of us. So thanks once again for involving our society, Bangalore Society of Obstetrics Gynecology, along with Madam Dr. Uma Devi, our secretary. Again, thanks to Sonali for coordinating, joining all the people together in one platform. Thank you so much. Without much ado, let us proceed. Thanks for taking us as chairpersons. Today's talk is the first talk is on one-stop fertility assessment. And sir is Dr. Karunakara Marikinti. Can I have the sir CV if you don't mind? Welcome, Karunakar sir. We are here to listen to you. We would like to briefly introduce you to the audience here. I would like to have his CV, Sonali.
Mr. Himanshu, can you display? Yeah. Thank you.
Yeah, that is too small for me. Yeah, thank you so much. Sir is a, yes, consultant IVF, reproductive endocrinologist, and in the Department of Obstetrics and Gynecology in UK. His expertise is simple, complex female and male infertility, multiple miscarriages, complete range of IVF treatment, especially the genetic testing part of it, fertility preservation, especially oncofertility, office hysteroscopy, and many more. 3D, 4D ultrasound is also one of his interests. Thank you, sir. With such an illustrious CV, you are in front of us. We are very eager to hear to you. Thank you, sir.
Am I starting?
Yes, please share your screen.
Yes, sir.
So kindly let me know what is the time that I have. Is it 40 minutes?
Yes, sir.
All right. So then I have two versions of this presentation. One is a condensed, the other one is an extended. So I will leave it to the audience or the panel to tell me how far I can trade into the extended version. It depends on the curiosity and secondly, I'm assuming the seniority of the people who are listening. I don't be reading the slides. I rather give the essence of the slides. So therefore, there is a larger content. It's basically the experience-driven presentation. It's not something we do for medical students. It's meant for people who just want to use ultrasound to maximize the efficiency in infertility services. So I chose to, there is a dummy model that I'll be hands-on constantly playing with here. And I just took off an old probe. This is the 3D probe. So it depends on the level of whether people are practicing infertility in a primary setting, secondary setting, tertiary setting. So I would like to titrate as much as possible. Some of the people you may be doing better ultrasound than me and having a better setup. Some of them might be in the primary or secondary case. So you have to bear with me. Some of the slides are a little bit overwhelming. Some of the slides may be sounding too basic. It's very hard without knowing who is listening to me to titrate these lectures. So in these boundaries that I would like to take the opportunity to thank my parent nation, a proud Indian I am, and I'm still very deeply into Upanishads and Sanatana Dharma, and I take sound as Omkara. So for me, ultrasound is part of the Omkara. So I use it with every time I touch, I use ultrasound machine. It is the sound that is vibrating as life. So to that level, I use the service ultrasound. So basically, I would like to call this topic as a couple-centric fertility assessment or infertility assessment service. Not only it works as a diagnostic, but it does help in your stratifying the patient's prognosis, as well as complementing with the remainder tests. And the idea of doing any of these assessments as one stop or two stop or three stop is to be meaningful to the couple. Either you tell, you find out 90% probability the technology can assist them to be parents, or with 90% accuracy, you diagnose why science cannot help the couple. So these are the two meaningful relationships I have with my couple. So I have this free telehealth company called Wellbeing of Women London. I do free consultations across the globe on a daily basis. Whosoever cannot pay the consultation fee anywhere in the world, whether it is a simple or complex infertility or miscarriages, that's part of the WOW London or Wellbeing of the Women London. This is the most recent 5 weeks 3D, 4D ultrasound scan that you see being played upon. So I'll be touch basing not only the basic 2D scan, as well as the 3D ultrasound scan as we go along. What you see is the gestation sac, and the nipple-like structure you see is the yolk sac. Knowing what we know about infertile couple, I don't want to call it as a just one-stop fertility assessment service. It is almost a very, very comprehensive consultation. And the segments that include in this will be, this is the primary slides that I will be constantly referring to. A detailed, exhaustive, structured information gathering or history taking. This is done before the consultation starts. So the team that I established or the system that I'm used to in UK since '92, there is a methodology that goes into it. By the time the clinician with expertise comes in, he has got very brisk, pivotal role to play in ascertaining the overall condition. So it starts with history. I call the couple in the mid-cycle. People who have in that cycle, they're hoping to conceive. I try to call them just pre-ovulatory, but people are only coming for investigation and they're not planning or expecting a conception in the cycle, particularly multiple implantation failure, multiple miscarriages. They will be coming to me in the window of implantation. So whether it is scan, 2D or 3D, or it's contrast scan, 2D, 3D, or it is contrast scan of the fallopian tube, or the saline or liquid scanning of the endometrial cavity for assessing endometrium. All of them are included in that one. Those people with irregular cycles or the people who don't have regular cycles, I prime them, I prepare them as though they're going for frozen embryo transfer. So idea is to find the uterus or assess the uterus endometrium as many parameters as possible, as though the embryo finds it at the point of implantation. So that's the point about the female doing the mid-cycle scan. So either I do estrogen replacement or they do LH surge to assess the mid-cycle to time this visit correctly. Then comes the male. Obviously, there are many people that I deal with that already had a semen test, so I would have reviewed them before I see them on a Zoom meeting, before they assess them in the one-stop fertility assessment. Or there may be a category of 10 miscarriages or a 10 IVF failures. They have reviewed every piece of information already, and I call them in one go. For example, if you're seeing first time a couple, you can do the semen analysis. They're coming in advance to your clinic. Then you have the semen analysis to assess. You can do the andrology examination. You can even do, the radiological assessment of the scrotal sac and testis and groin. And you can even attempt. There are times where we do fine natal aspiration with an option to store the sperm. So most of the things can be done in one go. Of course, you can do the endocrine assessment. Once you've done male and female assessment in the setting, then you can validate to that level that their ability to create a baby, accommodate, feed a baby is in the green zone, amber zone, red zone. So that is the point I want to reach through this lecture, through the different number of slides that we have to go through. Now, obviously, ultrasound for fertility assessment, it confirms that the structures anatomically or distribution-wise, dissipation-wise, they are in the normal location and the findings within the structure. So that gives you specificity, or this test of this one-stop fertility assessment, whatever ultrasound you're using it for the abnormality of the fertility, whether structurally, functionally. So it is helping both specificity and sensitivity. I've been scanning from 1985 at AIMS and then since 92 in UK. Now, I believe in this training the eye to the 18 shades of whiteness, which is always there on the screen. So in contrast, we see more of the same. And that is the principle that I will be emphasizing a little bit more on contrast liquid scan, contrast air scan in this lecture. Obviously, from the known to the unknown, obviously, if you can see there is no normal ovary, normal uterus, normal myometrium, then you begin to think a deviation from normal, and then you go to abnormal, then you grade the abnormality. So in that sequence, the thought process comes in. So that is tissue to tissue contrast, tissue to liquid contrast, whether you can use gel or a saline, avoiding the air, and then tissue to air contrast, specifically addressed at the fallopian tube. It can be 2D, 3D, or both. I'm sure you're familiar with sagittal plane, axial plane, and coronal plane. This is again a 5 weeks gestation sac and yolk sac. As you can see, the septum dividing the miscarriage on the left side, and the right side, it's an empty. This was a miscarriage that you can, in one stop, it is not a fertility assessment, but people come there with miscarriage as the first visit coming to see me. So you can use contrast, liquid contrast, air contrast as appropriately. One of the highlights or the panel discussion that you have in this is the air contrast salpingography. This particular technique is discovered by me. I use human albumin, sperm wash media, to force air into the media to create foam, and then I use the foam. As you can see at 9 o'clock, you see the endometrial cavity, and this is the fallopian tube spreading, filling, flowing, and then spraying onto the follicle at 9 o'clock. So air contrast salpingography, or ACOC. using human albumin, which is again an evolution from HIFOC, hysteroform salpingography, which is one of my colleague Mark Hans Emanuel in Amsterdam presented his paper, where he had another paper at ASRM in 2007 in Georgia, Atlanta. This is again right fallopian tube. You can see the flow and then the spray coming more towards at 9 o'clock position. So this is air contrast salpingography. Now, a general discussion is that ultrasound cannot be an ultimate authority in telling the fertility is okay or infertility is confirmed. You must move on to much better gold standard tests, where so be it laparoscopy, so be it hysteroscopy, or MRI, CT scan, or second opinion from your senior colleagues who has more experience than. So, but then you must be aware of the limitations of using ultrasound, and that should be reported on your template so that you're not over dogmatic in your diagnosis with ultrasound of fertility or infertility. Again, knowledge is phenomenally an essential criteria. Training is no substitute, experience has no substitute, but those people who maintain their appetite for excellence, which is with the backbone of system, quality, and audit, you won't fail. Whether you are 40 years you have been scanning, you're still looking like a child looking for problems with a high index of suspicion. You're never senior in medicine. I'll just go structure-wise, but when I was overindulging in ultrasound, I'm very good in ultrasound, I keep learning lessons, and this is what I wanted to share in this time, that I thought the so-called beautiful trilaminar endometrium. Simultaneously, if you do hysteroscopy, you realize that I missed 4 pathologies. I'm the same operator doing both. I have world's second largest data on concomitant ultrasound, contrast ultrasound, and luteal phase hysteroscopy with vaginoscopic approach, without anesthesia, without dilatation. So I can confidently say my ultrasound corresponds with my contrast ultrasound. Is my contrast ultrasound corresponds with my hysteroscopy or not? So that is verification of your own findings. I will try to teach my experience rather than regurgitating some of the publications from here and there. So I sincerely believe in T. Krishnamacharya, who started the first yoga institute in Mysore Palace, that I rather tell what is relevant to you. And I expect some of this audience who are new to this branch of reproductive medicine, how efficiently to help couple without wasting couples' time and delaying their treatment and being part of their painful saga. You need to absorb the science with true emptiness first. Keep aside the previous and read knowledge to one side, and with an empty heart and empty mind, we approach science as it evolves. We have more chance of improving our science. If at all you're running a great fertility center, and if the couple is green profile, we will discuss that what it means. Your fertility one-stop fertility assessment should include you decipher with your all the armory of tests, whether it is scan, endoscopy, laparoscopy, doesn't matter, experience, all that. You must derive in a stage where is this couple in the green zone in terms of their ability to create a baby, ability to accommodate a baby, feed a baby, or they're in the red zone, or any combination. If it is green zone, there is no excuse anymore that the live birth rate should be 72% to 75%, 73%, with the transfer of less than 2 embryos. That is the benchmark you have to set up if you want to call as a one-stop fertility assessment. No country is a developed country in science. Every country has experts. Science is omnipresent. So if you take London or UK in 2009 data, in the 64 analysis, there is 18.5% is the clinical pregnancy rate in ranked 64th center, and the top center is hitting 52. I'm talking about Great Britain here. So if at all you decipher on one-stop or two-stop fertility assessment service, and you are accurate in your diagnosis and validating the competency of a sperm and egg and uterus and myometrium and blood flow, and also the receptivity, the hospitality of the lady and the general health, you are in a condition to predict 83% clinical pregnancy rate, still have some embryos left. So if I take cumulative pregnancy rate, we should be hitting in the order of 90% plus cumulative live birth rate if your assessment is accurate. Obviously, we are talking about assessment here, one-stop fertility assessment. It can spill on to second second stop also. But if in case your assessment is accurate and they're in the red category, even after multiple attempts, you're hitting less than 10% of live birth rate. This should be known to the couple at the earliest possible time. That's the purpose of this assignment. I believe in giving written information to and commitment to my couple. This is my consultation summary I drafted in 2008, and this 10th version that I'm doing it, I give to every patient. Page 1, diagnosis. Page 2, treatment options. It's up to the couple to decide what success rate, with what investment the couple are willing to pursue. My job is to give them where they stand and what are the options open anywhere in the world. Global options are open to them. It's up to them to approach depending on their resources and their own attitudes. How a man becomes father, there are hardware and software, the mechanisms and the tests, same applies to the female. I always start with why they come to talk to me. So this engagement, rules of engagement is always explicit with the couple. And I always emphasize, ultrasound cannot see the egg and sperm. Therefore, we don't even have a clue. I never say your eggs are good. It's follicle, it's the egg bag. So there's a lot of nuances involved with experience that comes to you. I say IVF is a diagnostic test. It can be a treatment as well. But unless you see again egg and sperm interaction, you haven't done the fertility assessment. So although we are using loosely one-stop fertility assessment, it's almost like polycystic ovary. There are no polycysts there. It's polyfollicular ovary, but we live with that word called cystic ovary instead of polyfollicular ovary. Similarly, it is not always one-stop fertility assessment. It can be a second review that you can do it on the Zoom. It can be one-stop miscarriage assessment service also. It can be one-stop uterine factor assessment service. These are all the things I established in UK or whichever country that I've been traveling outside AIMS, where I was there in 86 to 92. Since 92, I'm doing. So in a structured way, I give the commitment to the couple, and after having taken all their history, I profile them to green or amber red. Accordingly, their statistics will depend. My intention of talking to any couple is to give 90% probability of they becoming parents. It might take 6 to 9 attempts on the lane 1. It might take 6 to 9 attempts in the lane 2 of the journey, which is tablets and injections. You can couple that with IUI. You can couple that with IVF-ICSI. You can couple that with IVF-ICSI with genetic testing. Or you can do fertility-enhancing surgery with laparoscopy and hysteroscopy, a combination of all of them. But there is a format. A is embryo, B is uterus, C is the interaction between A and B, D is the general health. Every single consultation with every couple, every lecture that I have done, a number of times, we have now close to 4,400 people whom I taught whatever I learned over the last 40 years. So all of them follow the same format. General health or the systemic health, I always take serious note of. Whenever I give any treatment options after this diagnostic workup, there is the eligibility criteria. Once the people pass this criteria, only then this option is open to them. So every lane, every option to get to their 90% chance of having a cumulative pregnancy rate is determined by their diligent work, which includes the fertility assessment, infertility. This structure remains the same. But this is my ultrasound template. I want to spend some time with all of you, close to 90 odd listeners. Some of them you may not be using, this kind of 32 points that you're validating in your first consultation ultrasound, which is part of your one-stop fertility assessment of a female partner. Male, I'll come to that in a minute. The moderator, whenever you need to interrupt me, please let me know. And also just give me 5 minutes notice so that I know where to put the breaks.
Sonali, did you say that was 40 minutes? Sonali?
Yes.
In the brochure it was there. Yeah.
So will you tell us 5 minutes earlier?
Yes, sir.
Yeah.
Thank you. Please proceed.
So what I'm trying to mention, this is the commonest method that I approach. Every single patient, I do consultation scan. There are times I tell them that uterus is not hospitable, they need surrogacy. After 5 minutes of scanning, that's where the decision is reached. That also reaches whether that lady is going for abdominal egg collection. So I urge to my listeners that please connect me by marikinti@gmail.com. It's impossible for me to complete this lecture without going through most of the slide. I rather give part 1, part 2 of this because this is that exhaustive. And this means a lot to me. I'm not just finishing a lecture for the sake of lecture. Each slide is something that experiential learning. Since 85, I started in AIMS, and also since 82, somebody brainwashed me. Reproductive medicine is so attractive. And that is somebody from AIMS, Dr. Ramachandra. He showed the sperm. Since then, my addiction to reproductive medicine is ever increasing. So to put all of that into thing, I would like to share this presentation to anyone who is interested. I can do free webinars to any number of delegates, small groups, to explain these things. Otherwise, I won't do any justice to the material. So all these templates are freely available. I can give. There is a book I've made, handbook, 52 algorithm seniority. Obviously, one stop fertility assessment is part of it. So just to give you an idea, when I finish scanning, we reach a point. She's a hyper responder. She's a poor responder. She's a normal responder. Now, stimulation dose also, I decide as soon as I finish my consultation, unless there is a long gap. The other line here at the bottom I'm mentioning is that once I assess the uterine artery Doppler, I'm even predicting oligohydramnios, preeclampsia, even first consultation, before the first IUI, before the first ovulation induction therapy. So this diligence has to happen with the very first encounter, even before you pick up pen to write a prescription for ovulation induction medicine, let alone waiting for multiple IUI failures, multiple implantation failures, multiple miscarriages. Is too late and too little. I'm totally against such ignoring of the maximum details that can be obtained in the first interaction with the couple. Couple deserve that diligent, comprehensive, exhaustive assessment on day one they met you. Whether they had tried only for 3 months or 30 months, it makes no difference. The assessment has to be thorough, exhaustive, comprehensive, as much as that you are doing to your own daughter or your own couple family. So I take this template, I give it in writing, I give the images also to the patient, and it is all kept in the file. So the column 1, as you can see, a lot of details about once you finish scanning, you should proactively commit what you have seen, even type 0, type 1, type 2 submucous fibroid. That must happen in the possible. That's why I'm calling patients in the mid-cycle. I'm arranging saline scan. I'm arranging tubal patency test before even I see them for the first time, because I do free online consultation for the last 5 years for this couple. If you come to NHS, I cannot implement this. So one of the reasons I don't want to work in systems are I have to follow the escalator. You know, there is a ABCD system that I have to follow. Since I moved away from NHS, National Health Service, I have taken liberty to what couple deserves most, maximum possible information at the outset. So uterine cavity assessment in the column 2, endometrial assessment in the column 3, you will see ABCD. This is my own work in Bone Hall, Cambridge in 2003. I introduced histology-based endometrial grading that is adaptable on an ultrasound, which is ABCD grading. Again, left ovary, right and left head neck systematically driven. What does it do? It will tell you the summary. Is she suitable for vaginal egg collection? Yes or no? You know it even before you started IVF. Is she difficult IUI or ET? Because cervical canal is all messed up. You cannot see the angle in one go. So all these things put you into a true perspective, whether she need to go for laparoscopic hysteroscopy surgery before ART. All these decisions are reached even in the beginning. As you can see, the pain scale. That also tells you how she's going to handle any further ultrasound scan. As you know, it is embarrassingly cumbersome to the women. These are the background from which AIMS, Bone Hall Clinic, 2001 to 2008, Cambridge, Care Fertility, which is the world's highest implantation rate, St. Mary's, where I did most of my miscarriage work. They have their own IVF clinic now. So he is the pre-ICSI inventor, Simon Fischel, that you're seeing. Accidentally, his junior invented ICSI when this fellow was working with Susie. So I work in this model of ABCD, whether it is one-stop miscarriage assessment service, one-stop fertility assessment service. I routinely use hysteroscopy before even IUIs or embryo transfers, fresh or frozen. I don't wait for the first IVF failure, 6 IUI failure doing hysteroscopy, because it's free of charge. I do it in the luteal phase. It's without anesthesia, 4 to 6 cases done in the OPD. Everybody gets uterine artery Doppler done. They get told ultrasound cannot see the egg or sperm. So we don't tell them your eggs are good, your sperm is good, unless IVF is done. And I don't say I can see endometrium like a tongue that I can see with an open mouth examination, that ultrasound can ever show the details of what hysteroscopy can show. So people are put into the right perspective. And I also tell them the one-stop fertility assessment doesn't include assessment of embryo, doesn't include hysteroscopy, doesn't include the uterine receptivity, which is endotrio, decidualization score, and so on and so forth. Again, before male, I've taken the male history before they come. And I would have ordered them to do the genetic testing screening, or I do them when they come, endocrine assessment, so on. And then I specialize in erectile dysfunction and premature ejaculation. So to give a complete picture, most men willing to talk to a male fertility consultant. So one-stop fertility assess must always include sexual dysfunction, because if they're not ejaculating sperm or releasing sperm every 48 hours, the DNA integrity of the sperm is messed up. So you may be doing multiple IUIs with WHO criteria of normal seminogram. 1/3 of the people with normal seminogram has abnormal DNA integrity. Their IUI success rate will be less than 2%. So we are blinding ourselves without much the current knowledge. Physical examination, they take their own image with their own iPhone and then send it to me. I know the size of the testis is small or big. Every microliter of sperm speaks about the genital tract. So one-stop fertility assessment includes very thorough knowledge. I expect every clinician should have a very clear embryology knowledge. Otherwise, sometimes embryologists take you for a ride in your fertility center. So I deeply encourage people to be embryologists while they're practicing IVF. You cannot see the sperm. You cannot see the fertilization with one-stop fertility assessment. You can't even see the capacitation. So we need to know the limitation of one-stop fertility assessment service. I do routinely do the testicular scanning. If you do 10 of them, you will be laughing. It's one of the easiest things to do. If you do micro-TC 10 times, it's one of the easiest surgeries you ever do. As next cesarean can be the most stressful to you, but next micro-TC can be highly predictably easy thing to you. So I'm encouraging through this media today that you can learn pampniform plexus Doppler. You can learn how a normal testis look. If you do all your stuff, you know what is a normal male with fertility, how his varicose veins or normal veins looks like, how the testis looks like, how the vas feels like. You are very good in assessing fertility assessment before they become infertile. If there is more than 3 millimeters of vein, you know it is severe varicocele. And if it is bilateral, you can see the most recent publication of the great andrologist the world can be proud of, Dr. Rupin Shah. I'm an ardent disciple of his skills and his attitude towards profession. So I practiced micro-TC with him, and then anything that I do in male work, he's always next to my phone call. So if I say something about my male work, it is come from the expertise of the great Dr. Rupin Shah. So the varicocele diagnosis can be done within 1 minute with your own linear probe. So please take broader approach, and it's in 10 days, you will learn everything what I'm teaching in this presentation today. Just 10 days, 100 patients, no big deal. So you can assess male fertility, you can assess absence vas, you can assess normality of the testis, any testicular calcifications. Why are you doing all this? You are helping the couple. You are not running just one-stop diagnostic service. You are not a diagnostician. You are not a laboratory. You are a clinician. I'm talking to clinicians today. You are not a tester. You are going to provide a care. So it is one-stop fertility care, if at all you look at with a broader perspective. What that means is, once you see the truth that 33% of the so-called normal seminogram has abnormal DNA, and together putting DNA integrity and the greatest normal seminogram, you don't know the 50% competency is still unknown to you. So to say semen is normal, to call it as unexplained infertility, we need to be careful in using this language. Unexplained infertility is rather an unexplored infertility. Same applies to unexplained recurrent miscarriages, rather unexplored recurrent miscarriage. By doing this kind of understanding, by doing DNA integrity routinely, particularly the best two techniques or best three, examine, which is Shana Lewis from Ireland. The other one is tunnel technique from France. And the next one closest that comes to it is CASA. By doing that, even before you do any treatment, you know how to select sperm, even in a fertility unit. But without knowing the detail, inner integrity competency of the sperm, you are no wiser doing 3 IVFs, 3 ICSIs, and then asking for an expert, where the couple's retention rate in most of the IVF clinic is very, very low. That can be changed. I'm just pushing on to give some examples, knowing the time constraint. The endometrial thickness, I'm just moving on to give examples, is directly affected by endometrial peristalsis. So I want you to just have a quick look. What is the endometrial peristalsis look like? Most of the people you may know. I'm showing the left sagittal view of the uterus here. If you carefully look, endometrium is dancing like your esophagus peristalsis while you're hungry, or stomach peristalsis, your mom is cooking great food. You're just still kitchen waiting to eat. Your stomach is dancing. Similarly, wherever there is estrogen, particularly if it is more than 300 picograms, endometrium is dancing. This is the commonest reason for abnormal endometrial appearance, commonest reason for false positive polypoidal endometrium, commonest reason for underestimation, overestimation of the endometrial thickness. Does one-stop fertility ultrasound represent endocrinology? To a large extent, yes. At baseline, if the endometrium is thin, means it underwent ischemic necrosis because of the estrogen being less than 50 picogram. At that time, the new entry is going to commence. Usually 100 applicants, 90 days before ovulation, 20 for the interview. At baseline ultrasound follicle count, typically under 35, golden age patient is around 10 and 10, 20 under follicles. So you are starting the game, but you're already 10 weeks into the game of follicle development or monofollicular development. At this stage, you are confirming normal myometrial integrity and so on. But this lecture pertains to mid-cycle. So I will address only the mid-cycle here, where we expect to see one dominant follicle, you expect to see the remaining antral follicle, or if you missed it and you expect to see the corpus luteum, but still you can see the remaining antral follicle. This is all happening in the one-stop fertility assessment. You saw the location of the ovary, you see the mobility of those ovary, you can see the size of the ovary, you can see the physiological changes in the ovary, you can also see the pathological changes in the ovary, all in that one-stop assessment. If the estrogen is more than 300, 500 picogram, you see the trilaminar endometrium. Each endometrium is only 4 millimeter. I implanted in my mother uterus on 4 millimeter endometrium, not 8 millimeter endometrium. I want to bring attention of the listeners to this specific point. Human embryo needs 4 millimeter to 5 millimeter endometrium to implant. Not the so-called textbook learning that we all have. I need 8 millimeter endometrium, otherwise it's called thin endometrium. I will open the door to intuitively think what I'm trying to tell you right now. So this is mid-cycle assessment, which confirms. If in case the progesterone is between 3 to 5 picogram, you will see the thickening of the outer two lines. If the progesterone is more than 12 nanogram, you begin to see the complete white appearance of the endometrium. So you can even predict all this. So ultrasound in the one-stop fertility assessment is a fairly accurate representation of hypothalamo-pituitary-ovarian uterine axis. That is confirmed in my data. As I told you, I have world's second largest data of concomitant findings of the scan, contrast scan, and hysteroscopy and histopathology. This is in recurrent implantation failure, bone hall data, 400 patients in bone hall, Cambridge, published as a book way back in 2006 by Peter Princeton. So there is a high degree of correlation to histology, ultrasound, and endometrial findings. Late proliferative, early luteal, mid luteal, late luteal, premenstrual. These are all my own patients. Every single slide you see. Of course, this illustration is not mine, the top one. So endometrium, the requirement of embryo for endometrium to implant is 4 to 6 millimeter only. I graded this endometrium: A, early proliferative; B, late proliferative; C, early luteal; D, late luteal. Obviously, if you call her in third week, there is corpus luteum, you need to expect this type of endometrium. You can see the orientation of the ovaries, and when the fallopian tube is spilling, you must demonstrate fembrio-ovarian alignment. That should be the standard. Now again, I go back to the dogma or arrogancy I developed by knowing I do scan for last 30, 40 years. I have a great machine, $120,000 US. You need to be humble in medicine. The day that you are not humble, that you have more to learn, that is the day we need to retire. I thought it's a beautiful trilaminar endometrium. I expected this endometrium. Instead, I saw this 4, which means it is not conducive for implantation. Again, I saw luteal endometrium. I thought I'm damn good in identifying luteal endometrium, their progesterone level, their estrogen level, implantation said the thickness. I think I'm damn good at it. I expected this endometrial appearance when I put the scope straight after this the ultrasound. I saw these 3 pathologies. I felt so small, and I remain in the field of the vastness of relative science. In the vastness of the absolute science, I remain a dot, bindu. So I missed in the luteal phase hypertrophic endometrium, areas of endometrial atrophy, and endometrial varicose veins. My point of telling this is, please don't rely on ultrasound, whether it is you have $120,000, the greatest GE machine. It doesn't matter. It has a limitation. Hysteroscopy has to be your right hand. French people have been doing hysteroscopy in the OPD like a transvaginal scan for the last 35 years. I repeat, last 35 years, hysteroscopy is done in the office like a vaginal ultrasound. My first ultrasound workshop in AIMS was 1991 on low uterine segment. Trust me, I'm not fooling you. These images are not from that time. I just had an abdominal ultrasound. God knows when it was manufactured, when I was doing this workshop in 1991. I don't know what I was seeing, but I was running a national workshop on ultrasound and low uterine segment. So I was in my own euphoria at that time. Now, if I do ultrasound scan on a one-stop fertility assessment and a lady who comes with infertility with previous cesarean 1, 2, or 3, doesn't matter, with isthmosele, these are the details that you can study with a contrast 3D, which is already there. Mucosele is already there, so the mucus, and the bladder is there, urinary bladder. You can decipher each single layer with which you can predict the integrity of the scar. That's all I'm trying to point out. There are Leeds General Infirmary. I did the Royal College Diploma. This is the King's College London, where I did the advanced course with Devor Jevkovic and Stuart Campbell and Kypros Nikolaidis. Then in Bone Hall, I introduced the grading of endometrium. And yeah, so this slide I want to share with you that there are three types of endometrial changes in one-stop fertility assessment. You need to be mindful. In polycystic ovary, which bulk of your patients are, there are 4 types of endometrial changes or phenotypic expression of endocrine effect on the endometrium can be assessed with an ultrasound in 4 varieties. Those are friendly PCO people. They have kids. They don't come to you. You're just one of your staff. One day you are doing as a volunteer. The second one, luteal phase defect. The third one, endometrial hyperplasia or thick endometrium. The fourth one, no endometrium at all, because there is no estrogen, no progesterone, ovaries behaving like a testis because of the dominant LH effect on the theca cell, and nobody's bothered to convert the product of the theca cell into granulosa cell. So that's the story of PCO endometrium. You need to open your mind. There are books written, world conferences running on every month basis on PCO, but very rarely the endometrium is ever spoken of. You know very well, the oocyte in PCO is not aneuploid, but they have a higher risk of miscarriage. You need to be mindful. It is the endometrial factor. If it is thick endometrium, there are 4 types, subtypes. If it is thin endometrium, there are 4 types, subtypes. Because you already given 8 milligram of estrogen, called her after 12 days of estrogen, you have no excuse not to find normal, well-developed endometrium. So you're assessing the couple in the window of implantation as though you're doing frozen embryo transfer. Therefore, if it is too thick, there is a pathology. If it is too thin, there is a pathology. And for difficult embryo transfers, I've done an audit in Bone Hall again. Most of the difficult embryo transfer have cervical stenosis. So if you are seeing a patient on one-stop fertility assessment, people have a habit of doing mock embryo transfer during consultation, during pre-treatment workup. But I'm just telling you, hysteroscopy is far superior than ultrasound in assessing the ease or difficulty of introducing any gadget. All these are available to you on a textbook where I didn't emphasize here, but I compared ultrasound versus hysteroscopy, ultrasound versus contrast ultrasound, all 3, and with histology. All 4 combination you will see in the book chapter, Bone Hall textbook. This is London Women's Clinic. Why I'm saying this? This algorithm that I developed for the ultrasound is picked up there. I realized my own under follicle count estimation at the baseline is pathetically low sensitivity and low specificity when you look at mature oocytes I get and the number of eggs I get. I admit my own ultrasound estimation of endometrial normality is pathetically abnormal. My own estimation of antral follicle predicting that. I'm not trying to say here every one of you will make overestimate, underestimate, but it's a very common error. This is where I published, I did 100 people on tubal patency test with air contrast, where I found only one lady out of 100 people had bilateral tubal block. This is against my teaching in AIMS, where I used to do 8 to 10 hysterosalpingograms. 30% of them always had tubal block. By the way, in AIMS, I was doing a tubal patency test with blood pressure cuff connected with the Rubin's cannula. It's called air insufflation test, putting a stethoscope in the left iliac fossa, right iliac fossa. You are the same clinician. You are seeing me today talking about the hypophysi with 3D contrast hypophysi, and the same person who used stethoscope to identify infertility in All India Institute for 6 years, for your kind information. That's 86 to 92. Moving on to how the one-stop miscarriage service you can extend, one-stop uterine factor assessment. People come with multiple implantation failure to care fertility. There are 5 out of 140 IVF clinics in UK are managing multiple implantation failures as specialized clinics. There also, we call them for one-stop implantation failure clinic. I'm just giving possibilities to you today. Are there any indicators on ultrasound you can identify this lady is going to have a miserable embryo? Yes. These are all the pathologies in pelvis. There you are already with ultrasound scan. You're predicting she is going to be a nightmare for your embryologist and your, success rate in your clinic. You can do that. Same applies to the sperm also. You can find out post-testicular, pre-testicular, and varicoceles. So we'll just quickly go into, in ovarian regeneration, I assess them. They only come first time I see for ovarian stem cell. I identify is the ovary is salvageable or not. So for that, I take an effort to see access to the ovary, mobility of the ovary, immobility of the ovary, and pathologies in the ovary. I put special attention to it. I always share people a lot of mnemonics or storytelling when I talk about polycystic ovary, because 60% of your caseload or your business is from them. So I use a lot of storytelling. 100 applicants, 20 for the interview, one becomes the bride. My marriage happened like this. My mother saw 100 photographs. She chose 20 girls. Mine was an arranged marriage. I was stuck in UK wanting to be a for COG, MR, COG, whatever. So I used to go and then did the arranged marriage. So that's how it is. That's how PCO. I don't need to tell you all how the ovarian volume assessment needs to be done. How do you assess the antral follicle count and how you relate to the prognosis? And I mentioned, please audit your own figures. Don't assume somebody else's antral follicle count, somebody else's M2 is not. No, you have to audit your own cesarean section data, your own every subspecialty practice you are doing. This book exhaustively writes about ultrasound usage in stimulation of ovaries. There you will see how you measure the follicles and how do you underestimate them, how do you overestimate them, how 3D will improve the percentage of antral follicles count you see. It's exhaustively done in this. It's just yet to be published by knowledge base. When you look at the ovary, we go to ovary, tube, and uterus, just a few examples, and I'll close, open for discussion. So these are all the things you get to see in the ovary. Ultrasound will measure your antral follicle count. You must be not naive in missing the ovarian cancers. Regularly, you will face endometrial tumors. Don't be over dogmatic about it. And there are ways about assessing corpus luteal hematomas versus chocolate cysts. You don't need 3D for that. But just to give you an example, how I use ultrasound 3D. When I take this image, I'm telling my laparoscopic surgeon, I was a hand surgeon, laparotomy surgeon in my time, 86 to 92, working in an oncology unit with Professor Vijayalakshmi Barber. So my laparoscope skills are miserably low. But then I communicate with somebody who is going to help me with reproductive surgery. I tell them, if you're going to access this ovary at 10 to 12 o'clock, you're going to, you see the momentum and bowel here. If you're going to remove and say, happily celebrate, I've done a clever ovarian cystectomy, you are wrongly mistaken. This capsule is already ruptured between 11 to 12 o'clock. It went away from your even ovary. Now, if you're going to operate on this chocolate cyst with your classic great reproductive surgery laparoscopic surgeon you are going to destroy the only 4 antral follicle, which is between 9 o'clock to 12 o'clock. So what I'm trying to tell you here is your diligent 3D ultrasound of an ovary in one-stop fertility assessment, and you decide this lady needs reproductive surgery or fertility preservation before the reproductive surgery to debulk it, To improve the autoimmune dysfunction of the endometriosis, you must guide your reproductive surgeon who is not doing ultrasound in his OT. By the way, Antonio Waterlot, if you know him, he is the inventor of fertiloscopy. In all-in-one, he used to do caldoscopy, ovarian drilling, histoscopy, cannulation to unblock the tube. Master. His name is Antonio Waterloo, French guy. He was head of the department in St. Bartholomew Hospital, London, where I met him. I went 1 week. I went as a supernumerary observer to work with him for 1 year, so 1 week in France. I did the same thing to learn Asherman syndrome work with Mark and Emmanuel in Amsterdam. I'm still going to different parts of the world to learn how to improve my consultation to the infertile couple with the least possible visits. They don't need to fail 10 IVFs before they come to me. Let's go quickly. My old technique of assessing anterior-posterior view of the uterus was never there because I did not have 3D. Without 3D, you cannot have anterior-posterior view of the uterus. You cannot see the front view. So we rely on the dimension of the endometrial cavity at the fundus as to diagnose unicornate uterus. But now you don't need to worry about it. In the anterior-posterior view, you see in the Z-plane every single measurement. T-shape anomaly including, as you can see, unicornate uterus, septate, deep, irregular shape, you can't even explain, T-shape in the making. In the front view, in the right sagittal view, in the left sagittal view, in the anterior-posterior view, in the posterior-anterior view, in all views, you see I-shape endometrial chamber, that is unicornate uterus. If I have time for videos, I'll play the videos, but I just want to cover the topic. If at all you're going to proceed with the endometrial assessment, please be mindful of the grading. How do you measure the endometrial thickness? And choose by endometrial mapping, you can choose site of embryo transfer. I do the same thing endometrial mapping with hysteroscope. So at some point, you need to identify healthier part of endometrium. If most of the endometrium is damaged, you have to identify the best of the worst, like you do for abnormal sperm or abnormal endometrial surface. You can't just keep on operating and cause endometrial sclerosis. So you make her sterile from infertile. Many people do it. How do you do saline scan? How do you do tubal patency? To assess tubal patency, you need to build the pressure to 70 to 80 millimeters of mercury. For that, you need to occlude the internal loss above the internal loss. That is one method. You can use Foley's catheter, HSG cannula. But to do endometrial cavity assessment with liquid or gel, you need to stop it from leaking externally. So you need to block only the external loss. So that is the difference when you occlude internal loss, when you occlude external loss. You can use gel or water. Okay, now a touch base about contrast scan, which includes tubal patency test. Then, the rest is up to the panel to let me to extend, or otherwise I'll be going there only. The tissue contrast ultrasound, as I mentioned before, it can show the endometrium, the roots growing into myometrium very easily. Because of the bladder, I can see Nabothian cyst looking like a follicles. There are times people put needle into the follicles. Again, saline scan can be naturally, if you see mucus in PCO people, you see natural contrast scan. There's a lot of mucus that is always there. For those people who are in the primary level of learning, you can always see the bladder fold in the right sagittal or left sagittal view, whichever you're used to, up or down. You can see the angle between the cave of Regius, which is the superior surface and posterior surface of bladder. Here, you always see uterine artery to the left of the cervix and to the right of the cervices. And that is your arbitrary line below which you call it a cervical canal, above which you call it as uterine canal. Tomorrow, if you scan, you will always see the collapsed part of the bladder will be the best guide for you to know where you differentiate internal loss, below which you measure the cervical canal length, above which you measure the uterine cavity length. Without contrast scan, you're going to make blunders many times. Watch this. You think it's a beautiful luteal endometrium. This is healthy. This is unhealthy. That is the beauty of contrast ultrasound, showing polypoidal endometrium. If you want references, I can give you as close to 22 how saline contrast scan, salpingography with foam is far superior than hysterosalpingogram. In fact, they can come close to hysteroscopy in many ways. One of the clinics in top 5 clinics in UK, which best implantation rate or clinical pregnancy rate, they universally do saline contrast 3D ultrasound before the first embryo transfer, even before first IUI. And the two meta-analysis, 2014 and 2016, one says the routine universal hysteroscopy prior to transferring embryos and recurrent implantation failure increases the live birth rate by 30%. Prior to the first IVF, it increases, without even pathology, it increases clinical pregnancy rate by 25. In the same note, routine universal saline salpingography has got merits to offer to you. You can include into your one-stop fertility assessment clinic. The many evidences, these are all the indication for contrast scan. If you see liquid before recollection, after recollection, it will disappear. I have an audit on this. So once one good fundocervical uterine contraction is good enough to expel the mucus, if it's in the proliferative phase, nobody can remove this in the luteal phase. So whatever acts you want to do, uterine cavity fluid to prevent implantation failure, if you see it in the mid-cycle, you need to be alarmed because any layer of fluid will stop implantation 100%. Whether you put euploid blastocyst or not, it doesn't matter. With careful sonovaginography, putting a saline in the rectum and in the vagina in the one-stop fertility assessment, particularly when you suspect there is a frozen pelvis, indurated pelvis, when you do the vaginal examination and the anatomy of the uterus is not in the center, you can always begin to see the rectovaginal septum endometriosis, Pouch or Douglas endometriosis, and so on. You just need to train your eye. Be with somebody who will show you how the endometriosis looks in the rectovaginal septum. Or there are hundreds of brilliant videos. Join the ISWOG membership. Learn the modules of a reproductive medicine ultrasonographer. You are there. You are there. With willingness, you will get there. I do routinely saline scan, anterior posterior view, sagittal view, saline view. It doesn't matter. Nowadays, the 3D ultrasound is so superior without even any liquid, just 20 seconds of 3D on its own. I'm not doing anything when I do 3D. Only 2D, I need to put the probe vertically, turn it clockwise to do the axial view. Whereas in 3D, it does on its own. You can see the endometrial cavity with saline. You can see a tiny endocervical polyp. You can see adenomyosis in the making. That's what I'm trying to tell you. In the anterior posterior view with saline 3D, you are miles ahead in your pathology identification. You all know very well, 2/3 of adenomyosis is never reported, even if you see it. Although I keep seeing that, why should I report? Adenomyosis as an autoinflammatory condition. They have very severe dysfunction of decidualization score, which means abnormal uterine natural killer function, which means you may be doing the greatest IVF with a euploid blastocyst with the softest, ultra-sophisticated technique. There is integrity of the immune system in the endometrium dictates who will have multiple implantation failure, who will have multiple miscarriages. Sometimes you put the hysteroscope, you won't find a proper polyp. You take a biopsy from this, they say, just proliferative endometrium. I go through this every day in my head. Unless you have a reproductive pathologist, forget about it. They always give you proliferative endometrium or luteal endometrium, or if there is a precancer condition, they will tell you. But there is in between, there is something called reproductive pathology. You need to be mindful. So it's very common to see polypoidal endometrium. Please be liberal. PCO is a nightmare. I told you there are 3 abnormal types of endometrium. You need to fix each one separately before you start any treatment. Because once the endometrium is bad, you are not going to win by ovulation induction, agonist protocol, antagonist protocol, greatest blastocyst. It makes no difference. The soil is damaged. She is not going to go anywhere. I routinely do uterine artery Doppler. I take action with reverse diastolic flow or absent end diastolic flow. I routinely give nifedipine, which has the highest safety profile in pregnancy in the preconception period. There are multiple other endometrial abnormalities, not only thickness. A lot of people worry about thickness. Please be mindful of the morphology, texture. It's edematous endometrium. This you can see after giving, at the time of egg collection, if you see this type of endometrium and you know her estrogen is 300 picogram or you have given 12 milligrams of estrogen for 12 days, you see the endometrium. This is a case for surrogacy. You can remove adhesion, but you cannot generate basal endometrium by removing an adhesion. Not all adhesions have intact, viable stem cells below the adhesion. So let us not celebrate. I'm a greatest Asherman surgeon. We do something. How do you diagnose Asherman syndrome on one-stop fertility assessment? Endometrium doesn't look optimal. It looks suboptimal. Inhomogeneous endometrium leads to saline scan. It leads to hysteroscopy. That's all you can do. You can see in the anterior posterior view, polypoidal changes. This lady had 6 polyps removed. Still the polyp came. Pathology is that hyperestrogenic state. you don't treat with knives and daggers. You need medical curettage. When you see one polyp, be very diligent in identifying unevenly thick rest of the endometrium. It's only a matter of time. 6 months later, some other doctor will remove another polyp. Another 6 months later, another will remove. So the etiology of single polyp that comes in the post-reproductive age group or above 35 is totally entire ball game compared to hyperestrogenic state of polycystic ovaries that starts in the teenage, that runs into rampage by producing hyperplastic endometrium, not histopathological, but polypoidal endometrium. Bad enough to cause cauliflower-like endometrium, bad enough to cause multiple IUI failure, multiple implantation failure. Unless I fix it, I don't even do IUI. So my one-stop fertility assessment includes one-stop fertility care planning also. Can you see here, people saw one polyp. I can show you 3 polyps right away by putting a saline and taking an anterior-posterior view with 3D. You can see designs after design. We don't have time. So again, what does 3D scan can show? This is the left sagittal view of the endometrial cavity. I just rotated backwards. I'm seeing the posterior anterior view of the endometrial cavity. Now I brought back to the left lateral sagittal view of the endometrial cavity. Now I'm rotating, rendering to anterior posterior view of the endometrial cavity. Can you see the myometrial integrity, endometrial integrity, emptiness of the endometrial cavity? Everything like a glass, you're see-through endometrial cavity. What is the role of, what do you do in one-stop fertility assessment with myomas? What you can do is see that the plane of the myoma, see that it is, actually inside the endometrial cavity by doing a saline scan, and then do the hysteroscopy, assess the endometrial changes secondary to myometrial pathology, only then deal with the intramural pathology. Otherwise, we are following like undergraduate students, 3 centimeter I will remove, 3 centimeter chocklist I remove. See, up to one point, you have to be textbook follower. There comes the experiential learning. You need to go for what is the relevance of myometrial pathologies to the patient's outcome of embryo transfer or IUI, whatever you want to see. The endometrium has to be assessed. Only then you make the call. So just to show you, this lady was sent to me. These are all the cases referred to me. It's been almost 20 years now. I managed failed IVFs, failed miscarriages, multiple miscarriages or complex infertility. I take essential step to minimize further intramural surgery because invariably endometrial hypoxia is a consequence. There are many a times surgery is successful, they made patients sterile. This is very common. I can show in my hysteroscopy lecture, I will show where people are actually going with the tubular vision, where things are going wrong. So you can always see in a particular angle, the intramural pathology is not actually affecting the endometrial cavity. But if you superimpose, you overdiagnose. See, here also there is another video I can see. Here people think this myoma is impinging on your first scan, but it is not. So we need to be a bit more into it. Adenomyosis, you don't need 3D for that. 2D is good enough. This is after giving 12 milligram of estrogen for 20 days. There is no endometrium. This is a case for hysterectomy and surrogacy. You can always see the pinching of endometrium into the myometrial growth with the 3D easily, but you don't need 3D to diagnose adenomyosis. As I said, normal Doppler, reduced diastolic, absent diastolic, reverse diastolic. It's very easy. 1 or 2 minutes, you can learn. Just see the bladder fold, go to the right and left, you will do it. Now, just a couple of examples. This lady had bilateral salpingectomy, thinking this is hydrosalpinx. Somebody, radiologist, said it's all happened last year. This lady with TVS, she said there is a septum. This is hydrosalpinx. Okay. Then that fellow removed that hydrosalpinx. The histopathology showed para-ovarian cyst. The other tube looked red. So other tube was also removed because she was menstruating. You all know, my colleagues, that 70% of women during menstruation, the fundocervical contraction causing the menstrual blood to go into the vagina and outside, but that circumferential contractions are causing menstrual flow into the peritoneal cavity. John Studd has published this in way back in late 70s, early 80s. I'm sure you all know John Studd, Progress in Obstetrics and Gynecology. This is how right fallopian tube looks like. If you have 3D, in 20 seconds, the machine is doing it. You all know HSG. I don't need to show what is the trait for doing HSG. I always take a written informed consent. And I use, this is my own invention called ACOSI, air contrast salpingography, which is 5 ml of almond, sperm wash media, whichever media you have the highest almond content, take it, take 5 ml air, use the 3-way connector, agitate 100 times. Finish the job in 5 minutes. Otherwise, you re-agitate them, make a froth. If whoever is making egg whip to your kids, you will know egg white has the highest density of almond ever. Eventually, that's what I'm going to patent, egg white, for doing tubal patency test. This is under patency. If it is obvious hydrosalpinx, you are not jumping to do tubal patency test, you can see. You know, I love scanning these days. You know, my time in AIMS or wherever I 2D scan, I had no clue. First of all, hydrosalpinges, you miss them when you do at baseline. You know why? There is no estrogen. There is no secretion. You cannot see unswollen tube, full stop. It's too small to be seen. There is no liquid. With black, you can see white better. With white, you can see black better. You need them together in front of your eyes. Okay, so you can see it almost looks like a, you know, in AIMS, we have a crazy idea of doing tuboplasty after doing bilateral salpingectomy, salpingo-oophorectomy with hysterectomy. You know, 6 years in AIMS, 7th floor, sitting in the OT starting at 8, finishing at 6 p.m. was fun. Where we used to do a lot of, you know, experiments by doing tuboplasty while my professor used to remove this uterus and tube specimens. I'm telling, at that time, I didn't see hydrosalpinges. I can see with the 3D as though I'm actually inside the tube with the scope. It's amazing. Now, if there is liquid in the uterine cavity in the mid-cycle scan and you see hydrosalpinx, you know what to do. But if you do it the baseline, you are doing the wrong time consultation scan, you are missing hydrosalpinx. You're reducing IVF success rate by 50%. If you have a good 3D, you can see the tubal clubbing. You don't need 20 seconds. It will identify tubes are blocked or not. Just to give you another video clip, fimbrio-ovarian annulment is fundamental rather than just a patency of the tube. That's my request from now on for people. Just one of the, somebody wanted me to show. So this is an ovary here. Left ovary. Below the ovary is the tube. There's a lot of follicles. So the uterus filling the foam is at 9 o'clock. The fimbria is at 3 o'clock. That's the fimbrial spilling. This is the ovary with follicles in the center at 12 o'clock. So the tube is below, flowing below the ovary. There's no need for color Doppler to assess the tubal patency. You can see the filling of the intramural part, flowing into the intramural to the tubal part, and then you lose the contour of the fluid outline, the Milky Way, as soon as it spits out. As long as it's around the perimeter of the ovary, the fimbrio alignment is the acceptable quality. So this is ACOSI, air contrast salpingography. And again, you can take the epi view. This is again ACOSI. You can see the uterus filling the foam, foam filling the endometrial cavity, the right tube, left tube, there is a fold. You can see most of it, you can see it's just a static image. So I take a written report, I give it, I show them the evidence, and I'm just confirming efficacy based on the evidence as 2022 literature. And this is my own audit. I said 1% bilateral tubal block if you do with ultrasound base, otherwise 30% tubal blocks. You are forcing, you know, unwanted people into IVF because the pain and spasm and all sorts of things. And here is a little bit friendly with the patient. I would say it's patient-friendly tubal patency test. Again, this case was sent to me as a bilateral hydrosalpinx. I can see this is the left tube, right tube is also open. So this is the case, actual case I'm showing you here. This is the HSG report. How do you explain? You can say the 30% of pregnancy rate after HSG, I've been taught like that. So like this, so somebody flushed away all the mucous plug, and then I was successful to show the patent tube. So I shouldn't be blaming this X-ray, HSG, but I should say maybe something cleared off. But this gap was only 3 days. Uterocervical angle is very fundamental for difficult embryo transfer. You can measure it and you can predict difficult embryo transfer. Hysteroscopy is far superior, I repeat. And this is not one stop fertility assessment. So in summary, detailed history taking, calling them in the mid-cycle after preparing the estrogen phase, doing total examination of the male, including history I've taken before, will put you, this couple, into whether her ability to create a baby is in the green zone, amber zone, red zone. Accordingly, you decide prognosis with IUI, IVF with PGD, fertility enhancing surgery, ovarian augmentation, ovarian regeneration, testicular regeneration. It doesn't matter. The fate is written on the face if you are diligent in the first place. Don't wait until multiple failures, please. It's my request. You can run one-stop fertility assessment related to one-stop uterine factor assessment, one-stop miscarriage clinic, and you hold their finger throughout the pregnancy, even if you finish what you did. Kindly register with ISWAP. They have phenomenal teachers with modules, and they have outreach clinics. I'm doing the next program in different cities in the world. I keep running hands-on ultrasound training program. Minimizing the number of visits to the couple is fundamental. Maximizing the credible information is critical. And not doing unnecessary IUIs, unnecessary IVF is ethical. Do no harm. So these are all extended version. I stop here. I know I finished my 40 minutes, beyond doubt. So back to the moderator, or I'm more than happy to extend, but I just need to.
Thank you, Dr. Marikanti, for that wonderful lecture. We are awestruck with a lot of power-packed and all.
You can call me Karunakar, madam. I would love to be known as Karunakar.
Karunakar, yeah, that is my name too,
they
my
call
father's name.
surnames.
Yeah, I think we share the same name.
Yes, I saw yesterday.
Dr. Karunakar, this is wonderful. I think we are all giving a standing ovation from wherever we are for this wonderful lecture from our clinic and from our homes. Thank you very much. And what we have seen is only the tip of the iceberg, and we have to learn so much to reach your level. And over 40 years, you have mastered the one-stop, and you have showed us how we can do everything in the one-stop clinic, where we don't waste the patient's time, we don't give them tension. And most of all, what I liked best was you said that you think that it is your own daughter whom you're testing. Whenever a patient comes, look at her as a new patient and do all the tests stepwise, so that it is just like your relative. And that ethical aspect is something which is really applaudable. And thank you for that wonderful lecture. And you are not only the sonologist, you are the hysteroscopy specialist, and you are the radiologist as well, looking through the tubes, and you took us through the inside of the uterus tubes and everything. Thank you for the wonderful lecture. It's not enough 40 minutes. I think even 40 hours is not enough. And we all need, I think, an intensive training from your experience. Thank you very much, Dr. Karunakar, for that wonderful lecture.
More than happy to come and train anywhere. I'm a freelance consultant.
We would love you to come.
30 to 30 patients in single day. You will learn every skill from me in a single day. And
you're the one, your andrology also. So everything in one stop, because you don't have to depend on anyone. You even histopathology you can make out through the hysteroscope.
Our eyes are trained. We are gynecologists to begin with.
Yes. And it didn't have any of these effects by using this albumin solution for the.
It's a sperm wash media, Dr. Uma.
Sperm wash. Which is the most no side effects, nothing. If you have, there's more of air bubbles or something like.
No, the amount of air you use, 5 ml, and that 5 ml is in a micro bubbles. You cannot go inside a vessel.
Okay.
And you don't keep pushing. You gradually do it. Wait for the tubal peristalsis to come. And it is usually 2 ml. It will go to tube. So you still have a lot of foam left. And air embolism, if you know the mechanism of air embolism, you need to increase the pressure above the value of the resistance. You cannot do that here.
Okay. And some by using the lignocaine, the LOX gel. What is the experience?
Yeah. See, safety of the chemicals which are not tested in the embryology laboratory, I will do it with a pinch of salt. I have done, people are in Abu Dhabi, they're doing, I was, I cannot stop people doing whatever they're doing. But the point is choosing a material which is sperm friendly, sperm wash media. I'm comfortable, but I already initiated a research work to study the safety profile of albumin. If anyone interested, I'll give the research protocol. I have 32 research proposals to share with any of you on a brainstorming meeting, any institute.
What is the ultrasound machine you're using for this?
You give me any basic machine, 10,000 rupees, I will use it. Or the machine I'm using is somewhere between S22 or Nova I9. They're between 80 to 120,000 US dollars. But for doing 2D contrast ultrasound, you can use any ultrasound machine that you have. You don't need 3D. So I don't want to give a wrong impression that without money, you cannot become parents. That is not correct.
Thank you once again for the
Thank you
wonderful
so
lecture.
much, sir, for your excellent, elaborate, lucid lecture. Sir, everybody wants your email ID to connect with you.
That's surname@gmail.com, marikinti@gmail.com. MARIKINTI, Marikinti. It's a village goddess in South India. I belong to Tirupati.
Great, great, sir. So thank you so much, sir, for
Thank you so much, sir, for a very illustrious talk. Very nice. Thank you.
Any questions? If you have a question and answer session, you raise the hands and ask, because I'm used to doing almost 4,500 doctors that I'm involved in 100 webinars, 100 attendance webinars. So there is a session that happens after the lecture.
So I cannot see right now.
Okay.
You are giving your email
There are
ID.
still 107 participants. I don't know where they are, but yeah, I'm sure somebody has a doubt.
So you don't do the HSG at all now, hysterosalpingogram using the...
Look, there is no substitute for HSG if it is done and the way it was, the information it gives. I cannot throw away my professor's wisdom, right? So if you take Raul Margara, who is the pioneer in HSG, in tubal pathology, in microscopic tubal surgery. He's a South American. He worked with me in St. Mary's, London. For him, HSG is everything. And I can't go and tell him about hypophagy or acosy. So we need to, there is a room for his expertise, no question. But fimbrio-ovarian alignment can never be studied where you don't even see the ovary. And as you know, as soon as you put the probe, if you are putting a probe here, okay, in the vagina, you don't see the uterus in the view. What does it mean? It is tilted to right, left, or dextro-rotated, levo-rotated. So then, which means it indicates induration in the pelvis. So you then build your mental, lacunate towards looking for endometriosis, or you consider doing pelvic examination, vaginal examination to assess and go to the laparoscopy, because you can't identify stage 1 and 2 endometriosis, and that is enough to cause multiple miscarriages. That is enough to cause fimbrio-ovarian alignment disturbances. So we are still very antique time of looking for intra-ovarian endometrioma. Otherwise, there is no endometriosis. We are too naive. Same adenomyosis. 70% of people has endometriosis, adenomyosis. Almost 60% or 50% of adenomyosis people have pelvic endometriosis. And 1/3 of them will have abnormal immune dysfunction of the endometrium. You can fix anything, but you can't cause implantation, unfriendly endometrial changes due to adenomyosis. So we need to extend our thought, not just unexplained fertility. Semen is normal, tube is normal, your progesterone is normal. That is, I would say, very, very, very primary level of infertility care. You need to go to secondary, tertiary care.
Those patients with the recurrent miscarriage with adenomyosis, do you offer them immunosuppressant like this hydroxychloroquine? Because you said there is an immunological pathology that prevents the implantation, the killer cells. So do you use immune suppressants?
There is a 3 hours presentation on reproductive immunology. Next presentation, if you're going to stay there for next 3 hours. I'm just joking. So the adenomyosis is typically in the serum, there can be an overactive immune profile in the serum, which means the central government, the Army, Air Force, Navy are all agitative, but you go inside the house, there is depression. So there's an underactive immune system inside the uterus, and typically in adenomyosis, which means manic, depressive psychosis. You can say, how do you explain all this? This is the way it is. I can give you 11 cases where the serum immune profile is overactive, where you need to give them suppression, but inside the uterus, they are underactive. Many husbands are like that. They are very dominating in the office. At home, you know what they do. So endometrial immune profile doesn't always correlate with serum. If it is underactive immune system, I give immune stimulation protocol. By all means, arrange a group. I will do recurrent pregnancy loss lecture or webinar to any number of audience, anywhere, any day. It's ready. Presentation is ready. So distinctively, I subgroup overactive immune system that requires immune suppression protocol, Underactive immune system, I use immune stimulation protocol. They are not same. You can use the knife to cut or cut the vegetable or cut the finger.
Thank you so much, sir. So I want to stay for the panel also to guide us and give your expert comments in between. So thank you, everyone. And now we'll move on to our panel discussion. And Dr. Sonal Panchal, madam, is not able to join. So I'll share my screen.
Before proceeding forward, I would just like to introduce Dr. Sonal in brief. Please present her CV, the technical team. Please give CV of Dr. Sonali Agrawal. Yes, she is laparoscopic and IVF specialist from Agrawal Hospital and Research Institute, Gwalior, Madhya Pradesh. She is executive member of Indian Fertility Society, Joint Secretary, Gwalior Obs and Gynae Society 2018 and 19, Treasurer, Gwalior Obs and Gynae Society 22-23. She regularly organizes live surgical workshops in Gwalior. She is guest faculty at...
Sorry to interrupt you, that's fine. Everybody.
Okay, fine. So we will just begin with the panel discussion. Okay, Sonali.
Yeah, thank you. Can I share my presentation? Mr. Himanshu?
Yes, ma'am, you can share.
So start with our panel discussion. That is tubal evaluation, pros and cons of various techniques. It's gonna be very simple, and we'll move on very quickly. For that, I would like to invite our esteemed panelist. For that, Dr. Anuradha Kar, madam. She's a diploma fellowship in reproductive medicine. She is a director of Nurture IVF Bangalore. She is the member of managing committee, clinician ISAR. She's joint secretary Karnataka chapter ISAR. She's treasurer, and she has received many awards, and she's authored of many chapters in books. So I welcome you, ma'am. Next is Dr. Santosh Gupta, madam. She is the senior consultant reproductive medicine at Nova IVF Fertility, and she's joint secretary of Karnataka Society of Assisted Reproduction, executive committee member of Bangalore Society of Obstetrics and Gynec. She's received many awards, and she's invited faculty in various conferences. Next is Dr. Prashant Joshi, sir. He is a consultant IVF specialist at Cloud9 Fertility Hospital, Bangalore. And she has received many awards and have many publications to his credit. Now I invite Dr. Bangla Devi, madam. She is MBBS, MS and certified IVF specialist, and she's the director of Smile Baby IVF KC Raju Multi-Speciality Hospital, and she's presented many scientific papers, and she's invited faculty in various conferences, national and international. She's a president-elect for 2024-25. I invite Dr. Indu Madhusudan, madam. She is fertility consultant, obstetric and gynecologist. She has done the fellowship in reproductive medicine. She's clinical disorder, Samrudh Fertility and Urology Center, Bangalore. She has received many awards and published many publications. So I invite. And next is Dr. Sunil. He is a lead consultant obstetric and gynecology department of Esther RV Hospital. He is a director and senior consultant and director of ICA Academic of Advanced Embryology at Bangalore. So I welcome you all. We'll start with our panel. So this is our first So why to evaluate tubes? On ultrasound, tubes are isoechoic, so not seen normally until fluid in or around the tube. PIT salpingitis very common and cause damage. This means the tube can be identified on ultrasound when either there is hydrosalpinx or free fluid in the pelvic cavity. Tubal pathology comprises of 30 to 40% of infertility causes. Increasing trend because of PID, ectopic, IUCDs, endometriosis, previous pelvic surgeries, and salpingitis. So are tubes merely a pipe? Most people think fallopian tubes are simply pipe that allows egg and sperms to meet and fertilize egg to reach the uterus. However, in actuality, our fallopian tubes is a much more dynamic organ. The effect of this negative pressure sucking action plays best when the femoral end expands and covers the ovulation site of the ovary well. So not sufficient to know the tubal patency. It is important to know the modality of tube and the condition of tube lumen and fimbriae, tubo-ovarian relationship, as they told in their lecture. Function test versus patency test. While one full testing or functional test of the patient with infertility is not possible, so testing of tube patency is important as tubal obstruction is a major cause of the infertility. So here is my first question goes. What are the different tubal patency tests or the different modalities to check for the tubal patency? It's gonna be very simple panel. So I request our I can see Dr. Mangla Devi. You can answer.
Dr. Sonali. So, as Sir has already taken us through a very elaborate presentation regarding the evaluation of different factors in infertility. So, when it comes to tubal patency test, we can think in terms of a HSG, which is a very basic test. And though nowadays probably sonosalpingography has been, saline sonosalpingography has been replacing the HSG in a lot of places. And since most of us have ultrasound machine, it's very easy for us to do this test. But where available, maybe contrast sonography, contrast sonosalpingography is also very a test that can replace the saline infusion sonography. So I think where all else fails or where any of these tests are indicative of a tubal block, maybe the laparoscopy with chromoperturbation would be the gold standard. So these, I think, are some of the most common tests that we do in our center.
Exactly. So here are various tests for tubal patency, which is histolaparoscopy is the gold standard. Histosalpingogram, selective histosalpingogram, saline and contrast sonohistogram, hysteroscopy, 3D and 4D contrast ultrasound, MRI, CT scan, and previously we have that Rubin test, which is obsolete nowadays. And here is the diagram which is showing there's a table which is showing the different procedures we can use for the tubal patency. So what are the contraindication of tubal patency test? Can you elaborate, Dr. Indu?
Yeah, so the contraindication for any tubal patency test is there should be no pelvic infection and pregnancy should be ruled out. These are the two main things that we have to rule out before any tubal evaluation test.
Yes. So, of course, pregnancy is contraindication and pelvic infection. These two are absolute contraindication, and recent pelvic surgery are relative contraindication, and we avoid doing in a secretory phase because it can give a false, if it can have a pregnancy, it can disturb the potential pregnancy and women having menses, which increase the risk of infection, intravasation, and incorrect interpretation. So what is your preference for tubal evaluation in clinical practice? Patient selection in cases of different tubal evaluation techniques. Anybody? Dr. Prashant? Dr. Prashant is there? Mangla madam, you can take this. What is your preference for tubal evaluation in your practice?
So while there are a lot of pros and cons of different tests, for me, I think I would use the saline infusion sonography because it requires just an ultrasound machine. It requires a person to evaluate this and just saline. So it's quite simple and on the cheaper side, and it doesn't have the side effects of ionizing radiation that accompanies the HSG. So I would prefer that in my day-to-day clinical practice.
What about Dr. Indu? What is your preference and what is your case selection criteria?
Yeah, so my preference is actually HSG. I prefer doing HSG still, that I find it as a gold standard because it gives a lot of other information. I have no practice of doing saline sonography. And when it comes to patient selection for different table evaluation, so after the baseline evaluation of the pelvis for uterus and ovary, if I see that there is some adnexal abnormality in the form of where some kind of collection, ovary is not being accessible. They are not accessible, or they are in the POD, or if there is any adnexal pathology, it might be even the uterine pathology, then I would prefer doing a digital laparoscopy.
So that's why we have keep this lecture over here so that we all sensitize to do the different modalities and one-stop infertility practice, and we can add on hypocyo contrast in our practice, and we can add 3D and 4D in it. So who all are doing this saline infusion sonography, and are anybody here in the panel is doing contrast, and which contrast if you're using? Dr. Sunil, you are here. I welcome you all. Dr. Sunil, can you take this question?
Madam, yeah. Hi.
I cannot hear. Yeah.
I'm sorry. Yeah.
Welcome here.
Yeah.
So can you take this question? We are you using any contrast or saline to evaluate the tube, and at all you are using which contrast?
No, actually, I'm not doing saline, this contrast saline sonography. I'm doing saline histosalpingography. But contrast I've not used much, madam, because yeah, I don't find it to be really very useful when I'm talking about saline sonography, because objectively we do not have an clear-cut evidence to say, okay, we are seeing the tubes patent or not. Most of the time, when you talk about saline sonography, it is subjective. It's like the tubes are patent or not. Many a times it's so much of artifacts is there, patient is moving. So I somehow find the saline infusion sonography not to be that
That's
great
why
in the
we
practice.
kept this wonderful lecture of sir to sensitize everyone, and so that we can start using at least this contrast and get the beautiful results. So, Dr. Mangla, madam, are you using any contrast or only simple saline?
No, I've been using only simple saline. I haven't used any contrast. So if there's a block, I directly evaluate laparoscopy.
So the here are few prerequisites to doing the saline infusion. It should be in proliferative phase, and check for the absence of any free fluid, and check for any active infection. So what are the pre-procedure measures you take? Do we have Dr. Anuradha?
Yeah, hi.
Hello, madam.
Can you hear me?
Yeah.
Good evening,
but
everyone.
I can't see you, ma'am. Good evening.
So any procedure we do, the pre-procedure measure, I would say, will be a counseling. I explain the procedure to the patient. I tell them the pros and cons and any side effects. And if they agree upon, we go ahead and do. Another prerequisite is that rule out any infections. Especially I do a urine routine test for them, rule out any UTIs or any other linked infections, and then move ahead.
Karnataka sir, are you there?
Yes.
Sir, do you routinely use to rule out any urinary infections, or what are your prerequisites for that?
Renal evaluation in infertility patient.
So, sir, prerequisite, is there any, we should check for the urine infection before going for saline infusion or contrast
I'm not aware of the connection between the two. So I always do vaginal swab, endocervical swab in those people where there is a we have a pre-treatment visits before they see the consultant. There is a screening test done. Now, if you move on to the private sector, there are 21 bugs in PCR. It's a panel test. We do an endocervical swab, including HPV and vaginal swab in addition to it. And if they can't provide, they can give an urine sample also for the same. PCR can be done with urine sample, vaginal swab, endocervical swab. So infection screening, those people coming with complex fertility history, you should always do it. People with single marriage, just married for 6 months ago, expecting them for urinary infection contributing to their infertility becomes hard asking. But if they're symptomatic, of course, we do it.
So any analgesic or any, if you are catching the cervix or holding the cervix.
So my rate of holding the cervix is less than 2%.
That's great.
See, thousands of embryo transfers you do, thousands of hysteroscopies you do since 85 without any speculum. So then you just drive, you're driving in the same lane. But previous difficult embryo transfers and all, obviously you have to hold. I give paracervical block, intercervical block. I always give voltruil diclofenac rectal suppository, 100 milligram 1 hour before the procedure. Even before saline salpingography, but I stopped saline salpingography after doing 2 or 3 of them. It's my own imagination to see black against black and gray background on an ultrasound machine. But showing some fluid in the pouch is, as the other gentleman was telling, is not a conclusive evidence of anything. What I demonstrated is the air contrast salpingography. You have to see the entire track of the fallopian tube, filling intramural part, passage through, spilling over the follicular, over the ovary, and the entire direction of the tube. Sometimes you don't see entire length of the tube, but white is better to see against the black background rather than black seeing on a black and white ultrasound machine. So it's been hard. So ages ago, I had to do in NHS when I went from AIMS to UK. They were doing saline salpingography because it was popular at that time. But saline hysterography, I'm still doing. Everybody has uterine cavity assessment with saline for hysterography, not for salpingography. Once I started using foam, I won't go back. I want to see the white against a black background. I cannot see black against black background. My eyes are not good enough.
And so what about antibiotic? Would you like
Yeah, so as I said, either you do swab testing, see and treat, or I give universal azithromycin antibiotic, 1 gram per procedure universally, unless they're allergic. Allergic, I give doxycycline.
1 shot.
Yes. No, oral, 250 milligram times 4, 1000 milligram of azithromycin, oral prophylactic antibiotic, and 1 gram, 100 milligram of diclofenac rectal suppository. Yes, 5 or 10% of the time, I had to hold with tenaculum to negotiate the cervical canal, but that's part of our life. We are gynecologists, we find services not cooperating sometimes.
That's absolutely right. So move on
Another pre-medication, if you don't mind, I'll add is I also give atropine.
That's what I
because and one of the relative contraindication for any of the tubal patency tests, I would rather say, is severe seminal abnormalities. Then there's no point going and subjecting the women to all this invasive procedures and testing.
Is that classified as contraindication? It is unethical.
No, I would rather say it's a relatively contraindication. If it's a severe oligoastheno or azoospermia, what's the point doing all this thing unless we improve the seminal?
You must add DNA integrity test. You will be surprised to know if you do DNA integrity, you will be avoiding another 30% of unnecessary IUIs.
So how will you do the procedure and how you interpret your test?
As you've seen, my patients take YouTube with the phone shots. They see their tubes, 2 Milky Ways, right and left.
Right. And madam is doing saline infusion sonography. So how you interpret your finding? Dr. Indu or Dr. Bangla, madam?
Sorry, see, I don't do saline infusion hysterosalpingography. Actually, in Cloud9 they do. They use this saline infusion sonography, but they are doing this only recently from last 1 year, and they I know what they do is they use this gentamicin and then lignocaine, 1 ml of lignocaine jelly, and also this dexa, and they prepare the foam, and that is equal to 3 ml. They push it, it acts like a contrast, and then the 3D rendering is done. This is how they have been doing for past say 15 months. And because she's a sonologist, so she does this. This is how I am aware of. Otherwise, I don't know. So, and she says that this is really patient friendly and very comfortable for the patient. Before the procedure, she gives this atropine and then buscopan injection for a painkiller, and then followed by an antibiotic. This is what it's been happening in Cloud9 Center.
Just to add one comment, if I may, Dr. D. Tucker, if you know, she's retired. She was the head of the department. She was tuberculosis, champion in the North India in 86 and 80s and 90s. So she was doing this streptomycin mixed with something to put in the uterus as a tubal patency test, as well as whatever treatment for tuberculosis. So you're reminding me, 86-92 saga of every case is tuberculosis unless proved otherwise. All infertility patients are, like we say now, PCO is the leading cause of anovulation. Now they say, tuberculosis was the leading cause of any frozen pelvis, any tubal factor, any thin endometrium, any amenorrhea, any second amenorrhea, all of them, unless proved otherwise. That was my time.
No experience. This is what I gathered information from her, because I was curious to know what happens or what is the experience. It's only bookish or theoretical knowledge that I had. So this is what I got to know from this sonologist, very senior sonologist, who's been doing.
Once you use sperm wash media, you will not go back. It's there. Sperm wash media is there everywhere. 5 ml, yes. It's nothing. You just agitate properly, you will see the beautiful milk there. We all used to see milk.
Yes.
That is a wonderful technique, sir. We will all apply this in our clinical practice.
In your hands, it should be comfortable. No technique is good unless you enjoy it. And that's the hard bit of it. There's no going back, but a lot of people have aversion to new techniques.
So a saline infusion sonography doesn't give any information about the site of blockage and condition of lumen and tubo-ovarian relationship. So pre-procedure precautions during the procedures and adverse effect of this procedure. Dr. Anuradha?
Yeah, so the adverse effects can be, patient can have pain, patient can have vasovagal effect. Any procedure wherein we cross the cervix, they can have a vasovagal this thing, and patient may not tolerate the pain and may not be comfortable. So we sometimes may have to stop the procedure. So and also the adverse effects later, it could be patient can have infection, develop infection. So I think as a routine, we do give antibiotics to the patient.
So here comes one very important clinical point in precaution. Slow infusion of fluid or contrast media is very, very important to decrease the pain and minimize the tubal spasm. When there is a myometrial spasm surrounding the interstitial portion, the fallopian tubes and tube may not fill distally, and it gives the false impression of proximal tubal occlusion. Karnaka sir, in your practice, do you find or you can overcome this tubal spasm thing?
Yeah, so if I can go back to how my understanding of the labor pains preceded by Braxton Hicks contraction, preceded by fundocervical contractions. In the ovulatory time, they're called cervicofundal contractions. In the implantation time, they're called circumferential contractions. So there are 3 types of myometrial cervical contractions. You see them as junctional zone contractions or endometrial waves. Endometrium doesn't dance. Endometrium doesn't have muscle. Endometrium doesn't have anything. So depending on the stage of the cycle, there is movements, 3 types of movements. Now, when you're doing tubal patency test, there is asymmetrical peristalsis in right and left fallopian tubes. Myometrial contractions doesn't correlate with tubal peristalsis. So please, we need to be mindful. We need to dedicate 10 minutes of very slow building of intrauterine pressure between 80 to around 80 millimeters of mercury in ultra slow motion. Then have patience, wait for the tubal peristal ostia to open. You can't force a milk to a child who refuses to milk. That's what we are declaring tubal patency, because when the doctor pushes, he expects the tube to be ready to open. Hey, madam doctor, gynecologist, force me, I'm ready to let your tube to go in. No, it is a sphincter. It's like anal sphincter. People can't just release their anal sphincter at will. There is a control. So you need to have this knowledge of how the uterotubal junction work. And we need to have patience for that. That's why sometimes I see left tube. Sometimes I see the right tube. Sometimes the foam is stuck in the fallopian tube. There is no peristalsis because it is a living organ on its own mind, its own rhythm, its own direction. So you need to have this knowledge of physiological contractions before you expect tubal pain. That's why this so-called 30% tubal factor textbook brainwash that I had for decades, it takes, undoing my learning takes time. It's 1% bilateral tubal block incidence based on 100 hyphosis. That is from inner London population. If you come to London, in the morning, there is a STI clinic, sexually transmitted infection clinic. Big queue people, they're spending nightlife and then they're coming for STI. Even in London, I don't find bilateral tubal block of more than 1%. What does that mean? We have been over-diagnosing tubal factor for centuries. That's because you're brutal. You put a speculum, you put a tenaculum, you put all sorts of things, put in a big X-ray plant on the head, and you run away wearing a lead. The patient thinks there must be something dangerous. The doctor is running away, go behind the screen. He's leaving me under the X-ray machine. What psychological pleasantness you are creating in a HSG? Nothing beautiful about it. So therefore, we are iatrogenically causing more tubal block and forcing people for IVF saga by not being understanding of the peristalsis of the tube, being subtle, using something that is more productive, more reproducible, more peer reviewable.
Dr. Santosh, are you there?
Yes, I'm here.
Yeah. What are the advantage of SIS over other modalities? Can you elaborate?
Yeah, so other modalities, if we speak about, there is a HSG to compare and there is a laparoscopy to compare. So first I speak over HSG. So in SIS, if we use small catheters, we can make it less painful. We can do it in our office. See, most of the gynecologists, we have scan machine at our disposal. But HSG needs a separate setup. So you have to send it to somewhere. So probably you can do it in your office. Then third most common important advantage is that you are doing scan together. So it's not only the tube, you are assessing uterus, you are assessing ovaries, you are seeing all other pathologies also. So it's a complete evaluation.
Yeah, exactly. Valid points. So it's the minimum patient discomfort and non-invasive AC to perform, and it is not required any radiations, does not require sedation or anesthesia, does not have any major side effect or severe related complications. So this is a really very good test we can opt for. And as we discussed, Dr. Indu can elaborate adverse effect of SIS. It can be slight pain, nausea, vomiting, and related infections. And sir told in 1 or 2% there can be stenosis at cervical os. It can be negotiated in between. So move on to our next question: limitations of saline infusion sonography in detecting the subtle tubal abnormalities. Dr. Mangla, would you like to take this?
So as sir has also mentioned, so saline infusion sonography could probably just say if there's a tubal block or not. So, but the site of block cannot be made out with just plain saline injection. So then hycosi might be more important. So that's one of the major limitations as far as this is concerned. Otherwise, I think it does correlate with other, things, and this tubal spasm as well, it can be one of the limitations. But as sir said, if we push the saline, probably take 10 minutes and push it slowly, maybe that part we could overcome. And giving an anti-spasmodic like Buscopan a little earlier, half an hour prior to the procedure, kind of, we can overcome that particular problem. But these are the two limitations which I think are something that we commonly face during SIS.
Exactly. So we obstetrician gynecologists using saline infusion mode rather than using contrast. So we do have sometimes we cannot, it's an indirect visualization of tube so that we can see the fluid in pouch of Douglas. So we are not delineating the tube.
Here again, Dr. Sonali, I use a Doppler, to visualize the spill.
Yeah.
So that
we'll come on that part later on. So tubal spasm is a misleading and misinterpreting anatomical distortion of torsion and difficult to assess the full length, like in cases of endometriosis or previous surgeries, and saline flow dynamic pressure applied and volume of the saline used affect the accuracy. The patient's factors, variations in uterus anatomy and the pain tolerance and the uterus position can impact the efficacy and clear image of it. So what other variations in this technique to overcome these shortcomings, or other modalities better than this? Dr. Indu?
Though I have no experience, I think the other modality is using the contrast. Sir would be a better person to answer. He has given such a wonderful talk. It was really mesmerizing.
Right.
He can talk on this.
Some
Or
contrast.
can take this. Any other panelist can take this if they are doing this.
We can use the microbubble, and these are the list. We can use Hycoside with the microbubbles, with the foam gel, and contrast media. So what different contrast media we use for Hycoside? Dr. Santosh Madam, can you highlight? Mangla Madam, can you?
I have not used, so I think Sir would probably be better to enlighten us.
Sir, this question is for you. So you are using the media, but are you using other like gel or Sonoview contrast media in your practice?
No, I don't use any of them because they're expensive and they have listed side effects, but sperm wash media is the only one I use. Exam gel is $200 in this part of the world. It's 200 pounds in UK. And if I can do it for £2, why should I charge 200 pounds to the patient? Secondly, they haven't done phase 1, phase 2, phase 3 trials in infertility factor in any of the single ones. Nobody did endometrial injury, tubal endosalpingeal changes, and peritoneal changes at the point of spillage. None of them. I will never approve them. Full stop. I live in Cambridge.
What
I
about
don't follow somebody who doesn't come up with any evidence.
Right. So what about Sonoview?
The same. It is just a media. Radiologists, these are all radiologists spillover. You know, radiologists are better ultrasonographers than gynecologists for centuries, right? So they are selling us contrast media.
So like Sonoview is using for vascular studies and many diagnoses of malignancy. So sir, can we use like it's being used?
My concern is, can any of us in this body produce an evidence it is endometrial safe, endosalpingeal safe, and peritoneal safety, and also safety to the embryo, safety with the sperm, because the oocyte, sperm, or they all depending on if the endometrium is chemically inflamed, how are you going to stop it from misbehaving with an embryo? If the endosalpinx is chemically irritated. So without studies, we are discussing it's an academic activity. I'm from All India Institute. I live in UK since 92. I can't say my personal opinion.
Right. That's true.
There's no personal study. I haven't done any work.
So now onwards, we also use the washing media or media for this.
So do we need to dilute to the sperm wash media with saline, or we can directly use 5 ml?
Sorry, Mangala Devi, are you talking to me?
Yes, sir. Yes, sir. So I just wanted to ask you, sir.
Yeah. So the procedure is you choose whichever oocyte friendly, sperm friendly, embryo friendly media. If you know the originally first IVF baby, we use the lamb cough serum. So in our own serum, in our own plasma, we have rich protein that traps the air for 5 minutes, 10 minutes. So you need to agitate. 5 ml with 5 ml of air is enough to produce 10 ml foam. But what happens is, if your albumin content is not good, if the temperature you directly take from the incubator, directly you might have taken from the fridge, this media, and how long you left it in the room, all these things changes the physics of the fluid. So the foam retention time can change. Sometimes it becomes water separates from the foam, the albumin. So then you need to agitate again. That's all. Usually 10 ml foam for a uterine cavity with the patent tubes, I'm sure you understand, 10 ml is an adequate amount for you to establish. But if you're going to declare block tube, I'd rather use another 10 ml of foam unless she's in pain. Because once you write off her, right, she's a case for depression. IVFs are not going to bring child to all the people who are with their tubal block. So for me, I'm very sensitive. I have to become patient. Otherwise, I don't talk to any single patient. I'm sensitive to even what I'm talking. Manasa, vacha, karma. It needs to be that attitude.
So thank you, sir, for insights. So next question is how you can make SIS or hypocyte better and painless by adding 3D and 4D. Anybody's using this 3D, 4D?
You saw 3D, 4D that have shared the images. You know, I am not showing the 4D videos. There is a big extended part of my lecture. I haven't shown anything. So how can you make hypho? I can only talk about hypoxia, or I will call it as ACOSY, air contrast salpingography. How can you make it better? So far, I don't need to make it better. I can see whiteness flowing in front of me. If you see all the 100 videos I'll give you, you will say you can see white on a black screen. The next question is painless. You can't make painless for a wimping patient. She is depressed. She is PCO. 10 years she did not have kid. She has difficulty intercourse. You're going to have painless hyphoxia with her? I'm sorry, you are imagining. You can't have imagination, right? There is a reality. Some patients are whinging. They have pain. You know, they don't like speculum. They're not having intercourse regularly. Or you're a man and she's a female. So please be realistic that some people, pain is impossible to get over. Then you do it under anesthesia. Give her conscious sedation. There's no one-way ticket in medicine. You're flexible, you last long. If you're inflexible, you will get stuck.
Anybody using pulse Doppler for the tubal patency?
I don't even bother using color Doppler for ovary, the follicle, the endometrium. There is no consistent studies. All of you, anybody's thinking of Doppler, please do uterine artery Doppler 3 times on the right side, 3 times on the left, and tell me how many different readings you will get. Then you will realize it is big blunder to use Dopplers in everything that you're thinking of. It is totally non-reproducible. I'm requesting 3 uterine artery Dopplers, right side, left side tomorrow. Tell me how many readings you will get. You will just resign to the fact it is useless.
So these are the advantage of 3D sonosalpingography. So, sir, 3D adding to hypocyte is definitely advantageous.
Sonali, are you bringing the questions from the people asking onto the screen?
Sir, nobody's doing, I think.
No. Is that what we are doing, panel? I mean, we are answering the delegates right now? I just need to know what I'm doing.
No, sir. Like, we need your expert comments over here.
These questions are drafted by you.
Yes.
Okay. That's fine. Go back to the question. I didn't know. I thought some doctor is asking the question. I was looking at the chat box.
No.
So it's not. Okay. 3D hypoxia added advantage. I already mentioned all these things are there. 3D, for example, is very costly. 3D jumping from 2D is very costly. Even if I say it is advantage, you feel more depressed. You know that is a good thing, but you can't afford. Patients also the same thing. I tell patients you have to do recurrent miscarriage tests in Chicago. They get more depressed because they don't have money to do Chicago test. So I have no business to make one patient more depressed. If agar 3D hota, मैं ज़्यादा, मैं information पता करता. But I don't have 3D. It's like charging patients for PGT, an embryo, and you don't know how to fix abnormal embryo. Then why are you charging patient to charge more? Throw the embryo away. But she doesn't want to invest to throw the embryo away. No patient will pay more cost in an IVF clinic. If you are going to test PGT, charging 2 lakhs, 3 lakhs, and then you throw the embryos away. He said, why the hell you tested? If you're going to throw the embryo away, unless you're going to fix it, why should I invest on a test without any treatment? So please understand, 3D, I don't see any advantage of 3D for assessing tube. No need at all. But in 20 seconds, it's like an MRI technician and an MRI expert. Please think on the analogy. MRI technician, you can hire 10 MRI technicians for a salary of 1 MRI radiologist. But once the technician finishes the 3D images or MRI, the radiologist coming in the night, he can render them, he can identify pathologies. So I use my 3D machine with my radiology Philippine nurse in UAE. She will do 20 3D ultrasounds, right? But in the evening, for 1 hour, I will come and render the important findings that I want. Because I'm just playing the baby doll in your hand, how to put the forceps around the head. You learn how to do forceps delivery by playing on a mannequin and a baby doll. It's exactly the same analogy. So somebody does 3D in 20 seconds, there is no false information. There is no false positive, false negative, because it has taken multiplanar MRI. 3D is nothing but MRI. What can go wrong with MRI? Is MRI beneficial? Are we going to debate, is MRI beneficial now? No.
Yes. So, sir, any panelists can take this question. When will you opt for other modalities of tubal patency? Like, what is your patient selection criteria, like HSG or diagnostic histolaparoscopy? Straightforward, not doing the SIS or lycoside. Dr.
No, I want you to maintain the word SIS is not for tubal patency test. SIS predominantly for uterine cavity, right? If you want to say, you have to say salpingography. Otherwise, saline infusion sonography doesn't always mean uterus or tube. If you can maintain saline hysterography, saline salpingography. Because I don't know what you mean. You understand?
Right. The topic was tube. So, anybody can, Dr. Mangla?
So if, sorry, okay. No problem.
Please go ahead, Dr. Anuradha.
Yeah. So once we do the baseline scan, if we see a pathology, other than, like endometriosis or a polyp or a fibroid which needs to be addressed, say submucosal fibroid, or we on history, supposing there's a history of dysmenorrhea, previous history of tubercular exposure, where we expect there will be a disturbance of the tubo-ovarian axis, or we see some hydrosalpinx and all. So in those situations, I would like to go directly for a diagnostic histolaparoscopy.
Right. So HSG can optimize the optimal delineation of the fallopian tube, allowing the detection of tubal patency, tubal occlusion, and the site of occlusion, and tubal irregularities, and peritubular disease sometimes. So HSG, there are beautiful pictures you can see here. So move on to our second last question. These are some disadvantage of hysterosalpingography, pain and X-ray exposure and contrast media exposure. So these are the few disadvantage of hysterosalpingography you can use. So if in any doubt or we want to remove any pathology or want to confirm or do polypectomy, we go for histolaparoscopy. Straightforward. It is a gold standard for the tubal evaluation. Like here is some pictures, post-surgical adhesion of the tube to the anterior wall, and this is the grade 4 endometriosis. These are some peritubular adhesions we can see beautifully, and this is the picture after post-adhesiolysis, and here we can see almost normal tubes, and here when we are filling it with dye, it's showing the mid-tubal block, and these are some hydrosalpinx picture we can see. So laparoscopy is always considered as the gold standard, and adding to hysteroscopy, we allowed the evaluation of intrauterine cavity with the identifier of congenital or endometrial abnormalities, and simultaneously we can correct it. So we'll end our panel discussion over here. And to conclude, the sonosalpingography can be used as an initial investigation for the infertile patient, and laparoscopy can be deferred for 6 months. Meanwhile, endocrinology and the immunological causes can be ruled out if required. Laparoscopy can be done. SSG can be used as a first-line evaluation with tubal patency in infertile workup. HICOSI is a suitable outpatient procedure for the tubal patency assessment in women who are not known to have a comorbidity such as pelvic inflammation and previous ectopic or previous surgery or endometriosis. It is well tolerated by women and associated risks are minimal with this procedure. So I really thanks everyone and my esteemed panelists and Dr. Karnaka sir for this taking part in this panel enthusiastically. Thank you so much, sir.
I want to ask one question to sir.
Sure.
Yes.
Sir, you said that the HICOSI that you do, you see only 1% of blockage, tubal blockage.
No, in that study, it was in 2010, one bilateral, 13 were unilateral block.
Okay, the type of blocks, sir? No, no hydrosalpinx or just what kind of blocks?
No, hydrosalpinges, I tend to see it, see, first of all, you explain to me what is the mechanism of hydrosalpinx. Both medial and lateral end should be blocked. So when the medial end is blocked, how are you going to push the liquid with force? Everybody, that's why in HSG, people demonstrate hydrosalpinx because you are using brutal inhuman force. But in an ultrasound, if you're really using 2 mil or 5 mil at the most, and if it doesn't go inside, the intramural part is blocked, the medial end, right? So then, to answer your question, where do you see? This is the time where people forced with fluoroscopy, still I'm telling you, in South America, fluoroscopy guided, the first you verify the tubal block, proximal 1/3, middle 1/3. The stories I keep hearing from South American friends. And they find somewhere in the block and they can metal wire and they probe it and they release it. They refuse to do IVF. Now, do you tell your professor today where you are practicing, right? You're going to with metal, you're going to force open the fallopian tube. Instead of IVF, she will just throw you out of the window. Indu, you agree or disagree?
Right.
So to know medial 1/3 block, middle 1/3 block, later 1/3 block, clubbing, this is my grandmother time when I was an MD in AIMS. This were my seminars, my webinars, my combined grand rounds, my combined clinical rounds. You read my CV. People tortured me with tubal factor in AIMS for 6 years.
Thank you, sir.
I was against stethoscope ke saath, I used to listen to the tubal patency. Poof, poof, tubes are open. So how crude I can be compared to 3D contrast scan that I'm doing? See, we have to embrace science. It should be useful to the patient. It should be painless to the patient. It should be least costly to the patient. You need to meet all these ingredients. That is called context-based protocol, not long protocol, not short protocol. Context to the couple, not what we think. What my father told, my grandmother professor told is gone.
Sir, if I may ask, in case of hydrosalpinx, it's not always necessary there's a block, right? So it could just be a tubal function abnormality as well, which is why, prior to IVF, when we see hydrosalpinx, we kind of do the clipping immediately to prevent, some kind of spillage of the fluid and, that may disturb the embryo implantation, things like that. So, it does not necessarily have to be that HSG, and so many times we've seen even with the hydrosalpinx, we have missed the hydrosalpinx and we have done it, and you still see even with the saline infusion sonography also we see the hydrosalpinx. So there we don't really use that much force, we can see it filling up.
With the tube is definitely hydrosalpinx, which is mucus due to block in 2 segments. In the middle, there is a mucus collection. You should be able to see with ultrasound.
Yeah, so what I'm saying is there are quite a subset of hydrosalpinges where there might not be a block. It could just be a tubal function abnormality. And, it's not necessarily that.
Yeah, time and again, there is a tubal fluid because retention of the fluid at that point in time when you scanned it. And with peristalsis, it can move away. So, but they're very small. It's very hard to see. I don't have experience to say, I keep on watching it how the hydrosalpinges disappeared. But tamponade effect is very well known. If it is not due to scarring, and if it is mucus, whatever plugs, once the pressure builds up, the peristalsis, it's like a constipated people, suddenly they open their bowels. You ask them to bear down, they just push it out. So this, this kind of high pressure dynamic changes happen. But the pathology is already there. How are you going to fix endosalpingitis? By fixing mechanical block. So tuber functionality is disturbed. That's what worries us, not about you either opening it, you're forcing, closing it, how many parts it's blocked, with what it's blocked, with what force you open. It's about the ciliary activity of the endosalpinge. So that is called phelloposcopy, for your kind information. I use the language fertiloscopy in my presentation. That includes phelloposcopy. So we put a tiny flexible hysteroscope through culdoscope in France. That's called fertiloscopy. And we go into the outer 1/3 of the fimbria to assess there is a normal endosalpingeal changes. Now, are we doing phelloposcopy before you decide this tube is IUI suitable, natural pregnancy suitable? It is scarce, that skill is scarce, that scope is scarce. We're talking a lot of theory here. I think I'm very patient-centric person. My title heading is patient-centric. I'm not even doctor-centric anymore. I'm gone. I'm no longer doctor. I'm just part of a family of a couple who comes in front of me. This is academically, it's okay. But then how many 40 years of academics I'm doing? But I want to change the landscape of infertility. Say, for example, I'll be doing vaginoscope, the vaginal ovarian drilling. I'm going to introduce the technique all over the world. Just with a modified the egg collection needle, it cauterizes. You are just doing a normal egg collection procedure. I don't do anesthesia for vaginal egg collection in Sheffield University Hospital. We do 800 egg collection. There's no anesthesia. So once you go inside the ovary, you activate the probe, you can do vaginal ovarian drilling. So 30% conception rate for it. You can save the laparoscopic hassle of laparoscopy, expertise, cost, all that. So I'm saying our next generation should change the landscape. For example, you are not giving cetrotide anymore in IVF. It's finished. You are not going to give micronasal vaginal progesterone anymore. It's finished, right? You are not going to do embryo biopsy anymore. It's finished. It's non-invasive PGT. What are you doing now? Science is already invented. Make it patient-friendly. Entire technology should be meeting the pocket size of an infertile couple, not rich infertile couple. They do whatever they want. That's what I expect for my audience. This is where my brain reached.
So I have two questions. So when you do histolaparoscopy in your patients, like what is your criteria for doing laparoscopy?
I don't do. I ask laparoscopic surgeons better than me to do it. I told you I'm a laparotomy person, 86, 92. Nobody gave me operative laparoscopy. Coming to hysteroscopy, I take care of every hysteroscopy procedure with MyoSure, TrueSure shaver system because this is the least traumatic excision of endometrial pathology, which is warranted for infertile uterus. For a fertile uterus, you can use any damn thing to remove any pathology to cause endometrial damage, endometrial sclerosis, that's done. So hysteroscopy has to have the nuances of plastic surgery approach. You understand what is plastic surgery. Hypoxia should be least. When you're using heat, hypoxia is maximum. 20% more than the base of pathology, you're damaging endometrium. And nobody is doing follow-up luteal phase hysteroscopy after doing so-called lateral metroplasty, septoplasty, septolysis, submucous dissection. The greatest hysteroscopic surgeons, nobody is doing post-procedure recovery of endometrium that is implantation friendly. Have you read any single paper anywhere in the world? That's where I disagree. People heroically doing, I did this surgery for endometrium, the Asherman syndrome. I did this I removed 70 myomas. What the hell have you done to the endometrium? This is infertility discussion, nothing to do with gynecological discussion. I hope you are getting the correct message. You need to have evidence of the endometrium is superior than what she came to you in the beginning with. Unless you show me, I'm sorry, I'm not part of that science.
So one clinical out of this all discussion, one of my patients, she was having, she's 34, married since 1 year, she's conceived 6 weeks, 6 days, and she's having cornual pregnancy with the bleeding PV since 7 days. And she was taking
7 days cornual pregnancy without pain. How do you explain to me all this? How is she living for 7 days in cornwall pregnancy? You're not
like
making
more towards
clarity to
the
me.
one cornu, not exactly the cornal pregnancy.
आपको पता ही है ना, the junction between the ostia and the endometrial cavity is nothing. She's just at the borderline. You take abdominal pregnancy. What happens in abdominal pregnancy? The placentation starts somewhere, but most of the placenta is connecting to where she's getting blood supply. So most of the implantation is in the endometrium. Least amount is in the endosalpinx. There's no problem. You follow me?
Yeah.
So the absence of pain, I question your diagnosis.
Yeah, it's more towards one cornu, not exactly the cornwall, but she's having bleeding on and off, taking all the progesterone, everything, and she came. So there's multiple polyps coming from the upper mid cavity from one cornu to the external os, and on per speculum examination, I can see multiple polyps coming, and we can trace with the color flow all they're showing the feeder vessels over there. So, so how to counsel that patient, like how to proceed as she's bleeding also on and off.
Yeah, you cannot change the outcome of this patient, right? So you have to hope the progesterone and the HCG is competent enough to multiply, and the HCG that you may giving maybe progesterone. See, the embryo at the point of implantation is 0.3 millimeter. Please go slowly with me, right? And polypoidal endometrium means, let us say 50% endometrium is polypoidal. You are telling polyps are coming. I don't care. Is 50% of endometrium polyp free? That's where the embryo will go and attach. Embryo is more clever than you and me can ever think of. You cannot do anything. Can you do anything to the polyp right now? You pull it, cause myometrial contraction, you will cause hemorrhage, and you will lose the existing ongoing pregnancy. Just wait. Nature will take its own course.
Right.
Thank you.
Thank you so much, sir, for all your insight. Thanks, my wonderful esteemed panelists.
This needs to extend into a structured, systematic learning of what is happening in ART field, in 3D ultrasound, in miscarriages, in PCO, to make life easy for the patients. Not that doctors intellectually growing big. No. How useful we are to the society where we are working, practicing medicine. It needs to reach. If you say ISWAG, this is a lecture, I am giving a message of International Society of Ultrasound Obs and Gynae. What they're telling, every woman should have, deserves, and she is eligible for highest quality ultrasound input anywhere in the world. That is the mission and vision of ISWAG, and I stand for it. I couldn't do that from AIMS. I couldn't do that. We don't have that penetration, the designing, the structure, the perseverance. Young generation, I'm looking forward to somebody who will take on. You extend ISWAG vision into the market or the community of wherever you live. Without ultrasound, nobody is going to do a great job. Without learning, nobody is going to do good ultrasound. Without identifying the extent of the infertility, you're not going to go IVF and not fix it. Take-home baby rate for IVF is only 35%. You go and check anywhere. Take-home baby rate is not more than 35%.
Yeah.
Still,
participants
are 70. How many are alive still listening to me? Are they still
There are
present?
some questions in the chat box.
Yes, Dr. Uma.
There are some questions in the chat box for you.
Yeah, I have typed as many. I will continue. I will never ignore any call that came to me, patient or doctor. Never. Same day, within 24 hours, I respond. My company is a free telehealth company last 4 years. Nobody need to pay me, doctor or patient, for anything that I know that I can help with.
So these are really things to ponder upon, I really am happy I joined this, though little late. I was in my OPD, but we really never thought like that, right, Indu? We don't think like this, We start centers and then we start seeing patients and our fellowships. We've done reproductive medicine fellowship. We go 1, 2, 3 in one line, I think we should think about it. Definitely. Though we are trained in ultrasound, I picked up so many new things today. I'm trained in ultrasound, but I think our vision has to change. Thank you so much, sir.
It is not an extend part 2. There is part 2 and part 3 to my lecture. I just followed it up. I kept it in backyard.
So
lot
here
of
are some
learning, sir.
questions. So here are some questions. Endometrial thickness 4 mm tri-laminar. Is there any role of stem cells, you want to ask?
No, I already answered that question. If you read my answer.
Okay. That's it, I think. Thank you so much, sir, for being with part of this academic session, and thanks everyone for joining, and thank you so much, sir.
Namaste.
Thanks,
Thank
everyone.
you for the opportunity. Without student, there is never a teacher. Without patient, there is never a doctor. So I'm grateful for that.
Thank you, Dr. Sonali, and the entire team and everybody. Thank you so much, sir. I'm happy to learn so many things from you. It was very nice joining this webinar. Thank you so much.
Pranam.
Thank you so much, all the chairpersons and everybody over here.
Okay. I would like to, again, I think we are enthralled with these lectures and with the experience, and I think we would like to have you further for the teaching session like this. We would try to correspond with you through the WhatsApp, but somehow the WhatsApp is not going through.
I have received quite a few WhatsApp messages already. The number that is typed is working.
Let's try again. So I had just thought about that fluoroscopic cannulation. One of the radiologists does it very well here, and proximal tubal block he's able to remove. So have you compared it with accuracy? He does it with the angiocatheter. Cardiologists use that. So
Sure, there are many such data in the communities, in the societies where the alternate options is not approachable, not acceptable. That needs to continue. There is a still place for tubal reopening.
Okay. And in vaginal drilling, you have, I think, you had mentioned about through the vaginoscope. How do you take care of the bowel?
No, it's not vaginoscope, just like an egg collection, but the tip of the needle is redesigned as a cautery, like a cautery needle. Whatever ovarian diathermy needle, the mechanism is in the physics, in the tip.
It's in the ultrasound, but how do you take care of the adjacent bowel and all? Because
There is not, you are inside the ovary, madam. You are not inside the bowel. Anybody who did egg collection is never inside the bowel.
Ma'am, polycystic ovaries will
Need a lot
be
of
bigger.
experience, I think. Because
Polycystic ovaries will be bigger in size. So it is easier to enter PCO ovaries.
That is not necessarily bigger ovary. Well,
Sir,
I'm used
generally on an average, sir.
Sure,
on
sure.
an average.
In vitro, if you are familiar
We'll
with
have
in vitro
multiple
maturation.
follicles at least. So if we have multiple cysts all around,
yeah, I'm
we
just
can
trying to
enter
explain.
easily.
Yeah.
Rather
So
than
the other point is, if you know how to see the tip of the needle, the bevel of the needle properly by facing the bevel towards the probe, you will see the brightest spot. So if you are any familiarity with in vitro maturation, we don't stimulate the ovary. We collect germinal vesicles. Within 48 hours, we convert them to M1. 4 hours later, we convert them to M2. Now, if you come to Oxford Fertility Center, Tim Child is the father figure. Somebody from Middlesex is in South India. Dr. Dakshinamurthy is one of the senior most embryologists of India. He does in vitro maturation for entire Chennai, Tamil Nadu. Why I'm saying this, you should be able to know how to reach inside a follicle of 5 to 9 millimeter anther follicle, safely aspirate the follicle and germinal vesicle. Otherwise, you have to improve your surgical skills. And all of us today have something to learn.
No, using cautery, monopolar cautery.
What is your question?
Do the drilling. When you do the drilling,
Yeah, like whatever we do in laparoscopic ovarian drilling, you are only doing subcutaneous injection. What are you doing? Nothing. You just poke a ovary, press the pedal. You are not doing anything rocket science. In fact, collecting eggs sometimes is more trickier. We're going along the edges. So anybody who knows how to put a needle into the ovary can put the tip of the needle into the ovary, press the pedal for an agreed calculated research time and take it out. Like the way you're doing laparoscopic ovarian drilling, you can do that. But I need to get to the point of redesigning the egg collection needle with that and also getting the same size as the ovarian drilling needle to go through the sheath. Okay, when these are all technical things, I'm working with the storage already. So you will just change the landscape of laparoscopic ovarian drilling to similar to a collection.
Sir, what about the heat dissipation in, in this vaginal draining? When you,
No,
I know you will be inside.
You are inside
and
the ovary. Only the tip,
yeah,
1 millimeter, 2 millimeter is diathermy sensitive.
is the
Nothing else is
diathermy.
going to touch.
Okay.
Okay.
Thank you.
May I take leave?
Wonderful. Yes.
Thank you, sir.
Thank you. I'll finish all the questions and then take the leave. So thank you.
Thank you very much. Thank you, Dr. Sonali, for this wonderful webinar.
Thank you so much, ma'am.
Being me part of that.
Thank you. Thank you, everyone. So now we'll close it.
Thank you, everyone.